So, hey, thanks for coming, y'all. I really appreciate this. It's 8 o'clock. We got about 30 or 40 or 50 people live streaming us also from all across America. So thanks for coming. I'm Eric Schmidt, the president of the Optometric Glaucoma Society. Honored to welcome you here today for a stupendous program. It really is. Murray's put a lot of work into this program. We're truly honored to be here at Bascom Palmer. First of all, thank you for hosting us. That's great. Second of all, we're really truly honored to be with the faculty we have today. It's outstanding faculty. The topics are going to be great. We're hoping, as part of the OGF mission, the Optometric Glaucoma Foundation, that's our education arm of the OGS. And our hope is that we can lift everybody up in this room and you can take that out and spread the gospel of glaucoma to your students and just, spread the awesomeness that is the optic nerve, I guess. So without further ado, again, I want to thank the sponsors too. We couldn't do this without our sponsors. Again, thanks for coming. We'll have a chance to chat with all of you at the breaks, but I'm going to turn it over to the designer of this program, Murray Fingerette. So thanks for coming, y'all.
Thank you, Eric. So my name is Murray Fingerette. I am now the president of the Optometric Glaucoma Foundation. And, we have, one of the things that the Optometric Glaucoma Society, started doing a while back was on a yearly basis, bring together the people who teach glaucoma in the schools and colleges of optometry. And we always thought that was important. And then it turned out that there was a risk of us running foul of the law. So we needed to get another organization together that was called a foundation in order to actually work with the educators. It was always the mission to in essence, teach the teachers. And what better, and over the 20-year life of the OGS, probably the person who was as important, if not more important than anybody in terms of the OGS meeting and teaching the people there was Doug Anderson. So back last, as I started thinking about what we should do for the next meeting, I said, what better way to do this than to honor Doug and see if we can include Doug. And then the thought was, well, for the first time, we've been on a rotating basis of New York, Chicago, and Berkeley, where there are 3 schools, and I said, for this shot, we'll come to Miami. And so it really, I'm so honored that number one, Dr. Anderson, that was allowed us to put this program together and work with him, and two, for all the faculty and folks here at Bascom Palmer for all their help, and Mark Dunbar and John Matsoli, really been amazing, and Mike Patella. And then finally, I have to mention Kelly Rogers for all the work that she has done with that. Now, the one thing I do want to mention, and then I'm going to turn it over to Mike Patella, is that if anybody here has an interest in going to the upcoming Optometric Glaucoma Society meeting, that's going to be, the day before the Academy of Optometry in San Diego, you're welcome to attend, register. You can you just would need to put a guest, and if you can just put my name or or anybody, but we would love to have you. So with that, let me turn it over to Mike Patella. And just as an introduction, if you don't know Mike, rarely has there been an optometrist that has done more in terms of glaucoma than Mike. And I don't think there's an optometrist that fewer people know. Because Mike was while he at one time was a clinician, it really was Mike as an instrument builder, as a developer, the strategist behind the Humphrey Field Analyzer, and a company that, while Mike is retired now, I mean, it was the HFA that he put together, developed with Anders Hale and that group over many, many years, and still doing things with it. So, you know, Mike is a Berkeley graduate. So, and Mike has been my friend and partner in a lot of these things over many, many years. So, and we really, I owe a great debt to Mike for all he has done, but in particular for all his help in putting this program together. So with that, Dr. Patella.
I've been to Bascom Palmer many times over the last 39 years. I first came here to meet Doug in December of 1983 to deliver to him a non-functional prototype Humphrey perimeter. It broke en route, but he was kind enough to forgive me that. And we've been friends ever since. So, and one of the things I've learned in the first 39 years is you better thank your sponsors. These are the people that have made this possible. They're footing the bill for us. And I thank them, each and every one, especially Bausch & Lomb, Alcon, Aerie, and Topcon. But if you look, a round of applause, please, for the sponsors. And like Murray, I must recognize the local organizing committee, the people who here at Bascom had feet on the ground in making all this happen. John McSully and Mark Dunbar. We put this meeting together for at least two reasons, and Eric has mentioned one of them, which is that the foundation's primary mission is educating optometry about glaucoma. And that's why we've invited you here. That's why we've made a place here, and we've minimized your expenses, and welcome, please. Thank you for coming. The second is that we're selfish. We wanted the people, the organizers, we wanted to have the pleasure of hearing the faculty of this institution talk on subjects that they are world-class experts at, and especially Douglas Anderson. He's been a member of the OGS from the very beginning, 20 years, and he's going to give 3 lectures today. Some of them, at least, via video, so he can sit back and take it easy and answer the questions that you might have. But he has really risen to the occasion and produced some wonderful presentations. I've had the pleasure of seeing them in advance. And Doug's accomplishments are too numerous to mention, but I'll mention just one. Nearly 50 years ago, he published a paper which was so revolutionary and so unexpected that his chairman said, "You're an assistant professor, you're a brand new guy, you're totally vulnerable. You should not present something that is this new, this controversial, and publish it for the whole world to see. They'll eat you alive." Yeah, well, he didn't know Doug Anderson. Of course he published it. But that paper taught us all what a glaucomatous optic nerve actually looks like. And prior to that, the descriptions just weren't accurate. So, and we all take that knowledge that vertical elongation of the cup of the optic nerve is a characteristic of this disease. And 50 years ago, we didn't know that. So it was so basic to everything. And for that, thank you, Douglas. That was a wonderful start to a long career that we have witnessed. Turn the page, Mike. If you have read the biographical profiles in this program, you may well have realized that this really is an all-star faculty. And I'll just list the names in the order they appear. Richard Parrish is editor-in-chief of the American Journal of Ophthalmology. you want a paper published, you got to get by this guy. Yeah. And oh, by the way, he was instrumental in developing the use of 5-fluorouracil back when in filtering surgery. And that was his first big project, I believe. Elizabeth Hodap, sitting next to John McSorley, has written along with Doug and Rich, perhaps one of the most important glaucoma textbooks that I have seen in my career. And it's called Clinical Decisions in Glaucoma. And she has a second edition now, after 30 years of that book, and hugely useful. David Greenfield is one of the most prolific glaucoma scientists and clinicians in the world. He really has done it all. And Steve Getty. Is Steve here yet? Yeah. Hey, hi. Steve has led the tube versus trabeculectomy studies for nearly 2 decades. Long time, maybe only 17 years. I've lost track, but 15 papers last time I looked on that topic. And he also serves the Academy of Ophthalmology as their chair for current practice in glaucoma, practice guidelines. Paul Palmberg is so impeccably qualified and accomplished that he is one of only 2 people to ever have roasted Douglas Anderson in public and survived the steely glare of Doug's mother. If you can imagine how far back that goes. You can figure out who was the second person to roast Doug. And Paul also invented the term target pressure and drove the advanced glaucoma intervention study, which showed that sufficient lowering of IOP can halt glaucoma damage in most cases. So we have people assembled for you that have done seminal work in glaucoma management and diagnosis, and they are here today very kindly. Thank you all to bring their thoughts to you. I'm honored and elated to be back here with my lifelong friends after 39 years. I think I can call them that. And thank them for agreeing to become faculty for this meeting. And we hope to see you in San Diego in a month. Thank you so very much. So with that, semi on time, I'd like to introduce Richard Parrish, who will tell you about his early and continuing experiences in managing glaucoma. Thank you, Richard.
I'm honored to be here honoring Doug. The best advice I ever received when I was a resident was, curiously, from George Spaeth, who said, "You're interested in glaucoma. I might be interested in having you come back. You need to go to Miami, where Doug Anderson will teach you things that I cannot teach you." Implicit in that, he would teach me how to be critical, how to think, and how to remain humble and humbled by a disease that we only incompletely understand. So this will be a chance to look at a 40-year experience. I'm now only 9 years away from being 80. So I have the luxury of looking back on my own life. The purpose is to determine how structural and functional tests among educators are currently used. And we're going to have a survey just in a moment. There are no right or wrong answers, but implicit in what we do, it must be an understanding that our students, those who are learning from us, will likely carry forward into their life and their practice those tests, studies, attitudes that we in self as teachers have. So education is in part mimicry by those who we teach. I will also suggest an approach or an attitude toward evolving tests. So let's look, if we could, we're going to go to a survey, and you should all be able to answer this on your cell phone. Again, the purpose of this is not, this isn't any gotcha moment, but I'm really curious to learn how you would manage these patients, or this patient. This is a 52-year-old man of Hispanic ancestry here in South Florida, and he comes in because he can't read. And he's an uncorrected hyperope. He's a plus 175 and EZJ1 plus at the appropriate near in 2015. His pressures are 28. He didn't know he had glaucoma. His angles are open. His corneal thickness is average. There's no pigmentary dispersion or PXF. How would you evaluate his optic nerve after you've dilated him on that first visit? So would you choose direct ophthalmoscopy? Would you use a biconvex lens, 66, 78, or 90? Or would you use a ruby lens? Would you use a binocular indirect ophthalmoscopy? Or would you use a Goldman contact lens? We'll give you about another 10 seconds. I think most people are going to respond. All righty.
Dr. Parrish,
Yes, sir.
you could also let the audience on Zoom know that they can also participate from home.
For those who are at home or are zooming in, you can also participate. I was just instructed. So the overwhelming odds are biconvex lenses are the most commonly employed practice for looking at an initial view of the disc. Well, let's go to our next question. Can you advance me, Rick? Or excuse me, Alex? There you go. So your exam confirms moderate cupping with infratemporal neuroretinal rim thinning, and there are no disc hemorrhages. What test would you use to document the baseline structural changes? Would you get photographs? Would you get spectral domain OCT? Would you look at a ganglion cell complex, GCIPL? Would you consider using swept source angiography or OCTA? I'll give you a few more seconds. And it looks like the winner here is A, B, and C, photographs, spectral domain for RNFL, as well as GCIPL. But a quarter of you would just use GCIPL and RNFL. Go to the next slide. So the studies confirm what you saw with your own eyes. There's intranasal optic nerve rim thinning with associated RNFL, GCIPL changes. How often would you repeat that test, assuming that there is adequate pressure control with whatever way you choose to intervene? Would you do it again in 3 months for a baseline? Would you look at a year for progression? Or would you wait a little longer, a year and a half or so? So it looks like we're fairly evenly split between 6 months and 1 year looking for progression. Next slide. So you do confrontation visual fields at the initial visit. And if you use a bowl type instrument for standard automated perimetry, what's your preferred testing strategy? Or is there another parametric study you would use? And I know this is a complicated slide, and I've tried to focus without any consideration that I'm seated next to Mike Patel, but most of these do center about. And it looks like we have a fairly evenly split number of people like 24-2 size 3, and whether it's a 24-2 or 24C size 3 are fairly evenly split. And our next slide, which I think is probably our last one. So the fields are reliable, which is remarkable given his first test. And there are no false positives or negatives. There's a mild supranasal depression. When would you repeat the visual field, assuming there is no observable disc change, no disc hemorrhages, and you deem the pressure to be adequately controlled? Would you repeat it in 3 to 6 months for a baseline, or wait 6 months to a year, or 1 to 2 years? Or would you not repeat the visual field unless there is some identifiable change with the RNFL or GCIPL? Well, again, it's fairly evenly split. There are more people who would do a repeat baseline within 3 months. All right, I believe that is our last slide in the survey. So we'll go to the lecture. So my history of structure and function. I did my internship at the University of Alabama in Birmingham. I did a straight medicine internship. I was pretty sure I was interested in ophthalmology, But I became convinced after I was on call every third night in Birmingham, ophthalmology was the right way to go. So how did we look at structures during my internship? I don't remember dilating a single patient when I was an intern, although looking at the optic nerve was considered part of a complete physical exam. And I can't remember dilating anyone. Visual fields, well, we would wave fingers and, there was a notion that if you had a stroke, things were either missing here or missing here. And essentially any patient who came in with a visual complaint was sent to the Department of Ophthalmology. I'm aware that there is an outstanding school of optometry at the University of Alabama in Birmingham as well. So let's see, Alex, I'm not advancing.
Just click with the mouse one time.
There we go. So how about my residency at Wills Eye Hospital, 77 through 80? We were doing direct ophthalmoscopy, oftentimes without benefit of dilation, rarely used the Ruby or Goldman contact lens. And my life consisted of drawing circles inside of circles to document the size of the cup. And there were no details about what the cup was or where it was located or anything specifically. Dr. Spaeth's patients frequently had 35 millimeter Kodachrome non-stereoscopic color disc photographs, but these were frankly rarely available or accessible for patients in the resident glaucoma clinic. How about functions? Well, what were functional testings for us other than, confrontation in the neuro-op clinic, where at least we learned how to do that? Goldman visual fields were available, but only when there was a technician available. And the octopus was introduced in the late 70s, 79, 80. Dr. Spaeth apparently mortgaged his home to buy one, which took up a small room, but this was not available for the members of the resident glaucoma service. Well, what happened during my fellowship? And this is not a plant, but the article that was referred to by Mike was a landmark publication in the AJO, happily to see, with predecessors Frank Newell. It was published in 1973, and it was co-authored by Ralph Kirsch, a practicing ophthalmologist in Miami, and Doug Anderson. It was recognized as a landmark centennial article, and it was the clinical recognition of glaucomatous cupping. And I'll show you some remarkable photographs. Almost everything I'm going to say after this can trace its ancestral roots to that publication in 1973. It focused on looking at not what was missing, but rather what was present. There was another article that was published in the late 70s, although the initial description of disc hemorrhages by Stephen Durantz occurred about 7 years earlier. So we became aware that a disc hemorrhage was something to consider. All of us were the recipient of fantastic stereodisc photography with Kodachrome colors and a viewer, and the separation was remarkable. It was so remarkable, in fact, that Doug led the education of all of the readers of the Optic Disc Reading Center for the ocular hypertension treatment study. That having been said, I did gain an appreciation of the value of the Ruby lens, which I regard as a near gold standard for looking at the disc. The Goldman contact lens is, I think, the very best, but it creates a coupling agent, it requires a coupling agent, it makes for a messy view. And if you're going to get photos or any kind of imaging study, you decrease the quality of that. Well, these are copies, and it's hard to imagine. These are published in black and white. They are stereo images, and with appropriate stereo technique, or if you can really crank in a big ET, you'll see these in stereo. And these are examples that Mike alluded to of physiologic cups in patients who had what we would all, I think, agree are a rather large central cup with an intact and in person, I'm sure, rosy pink colored neuroretinal rim. They may have some eccentricity with respect to the cup, but that which remains looks normal. These were two examples showing focal neuroretinal rim thinning superiorly. You'll see that toward the 1 o'clock position, the rim is much thinner. And in the bottom photograph, you'll see the remaining rim up top is not that cup, but there's focal neuroretinal rim thinning, which dives to the rim at the 6 o'clock, 7 o'clock position. These were examples of optic nerves that were normal, but could be confused with those that have glaucomatous cupping. These are largely the result of an oblique insertion of the nerve fibers into the scleral canal. And you'll see in the bottom one, there's a large area, this crescentic shape of peripapillary atrophy. I find it remarkable. These were published with stereo capability in a time when we think it's being technically far less sophisticated than where we are right now. I'm still not sure we could do this well publishing online as was done in 1973. These are examples of a cupping with focal neuroretinal rim thinning, which again confirm it's not the size of the cup that matters, it's what is remaining. What is the health of the remaining neuroretinal rim? For those of you who have access to the original article, this should be required reading, in my opinion, for anyone who is either in an optometric residency, an optometric student, or a resident in ophthalmology. Well, it was not in 77, but in 1970, Stephen Drance described a hemorrhage on the disc, and he thought this was a sign of an acute ischemic optic neuropathy and simple glaucoma. We realize that's probably not the case. We know that AION is usually associated with pale swelling of the disc. This disc did not have that. It had as a solitary finding this single streak-like radially oriented hemorrhage at the 1 o'clock position. A couple years later, he published 4 cases, all of whom had damage to their visual field. And you'll see in this one down at the 5 o'clock meridian, the so-called linear hemorrhage, splinter hemorrhage, or eponymously known as the Drance hemorrhage. He also published a study of patients who had, quote, normal tension glaucoma, and many of those had these hemorrhages. He looked for all sorts of general systemic findings, and the only thing that seemed to show that many of these people were hypertensive. Well, how about my fellowship? With respect to function, we had fantastic visual field technicians when I was here. I mean, they could do visual fields. Her name was Eva, and we referred to her as the Evatron because her visual fields were so perfect and reproducible. You know, frankly, the fields were not so great when done by fellows like me. And I think we became very, very well established in this community as a reliable source for looking at fields. And many community ophthalmologists would send their patients to us for Goldmann visual fields. The studies were completed and a report as well as hard copy was sent back to the referring ophthalmologist. Standard automated perimetry came on board shortly after I started my fellowship. My first fellow project here was working with the SQUID. The SQUID was a never to reach commercial success, kinetic automated parametric system. And it was called the SQUID because, you know, the octopus has 8 arms and the squid has 10. It has 2 tentacles and 8. So it was supposed to be octopus better. The problem was when we did the test, the thing would spiral around and it could never find, in some cases, the beginning of that isopter. So that it led to a peer-reviewed publication for which I was grateful, but did not have any clinical impact. Well, how about looking at the optic nerve now that I'm on the faculty for the last 40 years? Goldmann contact lens is the sine qua non. It's the best. I rarely use it. I love the Ruby lens. It is amazing to me how few faculty members use it. I know Janet Davis and I are the only ones I'm aware of, and Dr. Hodap, yes, and Dr. McSorley. And John has reminded me that very few of the brand new slit lamps actually have an attachment where you can put on there's no mount for the Ruby lens. And so therefore, the ascendancy of what you have all indicated, the binocular viewing with a stereo microscope of the fundus with either a 90, 78, or 66 diopter lens. In the late 80s, the notion came on board that, yeah, we can look at what's remaining, but we might be able to develop some normalized attitude as to what a disc should look like. Therefore, Jos Jonas published in a publication which is absolutely replete with numbers, but the take home of all of this is that if you think about discs on average, and I've heard David Greenfield lecture on this, there is a certain characteristic thickness in most patients, and it goes by the ISNT rule. Neuroretinal rim is usually thickest inferiorly, next thickest superiorly, then nasally and temporally. And if you notice, these are not area measurements, but rather these are linear measurements, radial measurements, showing the thickness in each one of these quadrants. Well, this is the Ruby lens. I love it. When I have optometric residents or fellows with me, I think they one of them said, well, what is that? And I said, well, you're looking at an upright virtual image, and what you see is what you get. So if you see something that's intranasal, that's actually where the neuroretinal rim is thinnest and there's focal cupping. I think also there's this question of which lens to use, and it sort of depends on what you want to see. If you're interested in a more or less non-magnified or minified view, I think most people are using the 78. I started out using the 90, but have morphed to the 78. I know there is the Super 66, which has no magnification, which is also nice to see as well. It's helpful to explain to your trainees, the reason you see a lot more when you're looking at the back of the eye is that there's a difference with the indirect lens compared to the contact lens. Well, how about my documentation of structure? Unfortunately, the beautiful 35mm sequential color disc photographs went away. We had simultaneous digital disc images, but they're no longer available. We do have currently here a NIDEC system for capturing images, but they are not true stereo. Click, click, and you create a stereoscopic view and hope that that separation is more or less constant. So how do the faculty members here regard visual documentation of the optic disc? David likes them a lot. Lee Allward, who was here, a wonderful fellow and very, very valuable contributing member to our glaucoma knowledge with respect to genetics. He's at the VA, although he's retired, and said he really misses them. And Alana Grzyewski is very keen about them, particularly as technology changes. Her opinion is you can take a photograph today and look at it down the road and not worrying about checking, trying to judge apples and oranges as various technology for imaging has changed. So this is a real world patient. This is a monocular woman I saw in July. She lost her left eye as a result of trauma at the age of 4. She was seen in 1978 with an optic disc that was judged to be suspicious. She had a normal visual field at that time. She came back in 2013, and this is how we were taking disc photographs at that time. I believe this was a TopCon system at the time. She then came back in 2022, and oh yes, she has peripheral retinal schisis, and everybody's, getting sweaty palms, wondering if she's going to detach. The retina people saw her and they love to take photographs too. So they got a wide angle image here looking at the periphery, not much value in looking at the disc, and you can see the schisis without any associated retinal detachment. But she finally came back, and here's what she looked like in July of this year. So if we compare where she was in 2008 to now, I think you would argue this looks pretty much the same. And having this degree of confidence in a monocular patient who has another ocular morbidity, I think is a reason to give us, to assure us and to assure the patient. So fast forward, she also had an RNFL, she had a GCIPL and a visual field. The field, despite the fact, tell people the fixation monitor was turned off for reasons I still don't know why. And if you look, something is not really cricket if you look at her RNFL imaging and you see the way that that is laid out. So I think fast forwarding, structure and function must fit. And clearly there was no evidence of any functional change, and her nerves looked absolutely the same. I alluded to the stereodisc photographs that were used to judge change in the Oates study that Doug basically was the primary educator for. And these were all available as stereo images. I'm not showing them as stereo just because I want to blow up a single image to give you an idea of how these were used. And it's pretty obvious, very much similar to what I showed you from the 73 AJO publication. There's inferotemporal neural retinal rim thinning at the 102nd month photo. And if you look in that area, you'll look down and see a very darker area in this wedge-like defect corresponding to where there is very little thickness of the RNFL. This was another image, a type of progression, which would be categorized as a diffuse enlargement of the cup without specific focal neural retinal rim thinning. Again, this was made on the basis of outstanding Kodachrome imaging. And this was another example of a more subtle diffuse increase in the neuroretinal rim. Again, these were all through the Optic Disc Reading Center that Doug led, the education of all of the readers. Well, how do we document structure currently? Well, I think there's been the ascendancy and decline of several images. The HRT, HRT2 and 3 came about. And I think it's fair to say that it does not enjoy widespread use in the daily management of patients. This is a confocal scanning laser microscopic system. Scanning laser polarimetry, and David has had great experience with that, came and then seemed to decline. There are many temporal domain systems, including OptiView, TopCon, Heidelberg, Zeiss, that I think are enjoying the most widely applied technique for looking at structure. Swept source angiography is still being considered, and I'm not sure if it's the chicken or the egg. That is, if you have no neuroretinal rim, you have no blood vessels. So which comes first? Do you lose vessels? Do you lose rim tissue? And I think that's still the subject of some debate. We've had a rapid evolution of visual field testing, from migration from the HFA to HFA2, and then to the Humphrey Zeiss to HFA3. There have been several landmark publications, including one in 1991, which was a comparison of analytic algorithms co-authored by Doug Anderson, Jay Katz, Al Summer, and Doug Gasterland. We've already heard your preference for moving to a specific type of strategy with respect to the CETA. There have been several other attempts, I think it's fair to categorize them, of parametric evaluations, including those manufactured variously by Dicon, Fieldmaster, Digilab, and then frequency doubling technology, which came onto the scene, at least initially, as a screening tool, and I think still finds some measure of applicability in that context. Well, what does the American Academy of Ophthalmology say? There are no rules. These are simply practice guidelines. And I tried to mimic those in the questions. You know, when somebody comes in their initial exam, you'll do a confrontation visual field. You'll look at the disc, and then you will look at the nerve fiber layer. When they come back as a follow-up, a suspect, and also if they have glaucoma, we understand the value of central corneal thickness, specifically in patients with ocular hypertension. The meaning of corneal thickness has still not been well established as a risk factor in people who have open glaucoma, although we all suspect habitually underestimating intraocular pressure may contribute to watching visual fields change with pressures that are normal. The Academy also suggests primary angle closure disease. You should look at the back of the eye, obviously with gonioscopy, or perhaps looking in the posterior pole through a gonioscopy lens, a technique that I was taught by Paul Palmberg, which is a marvelous way once you're able to steady the gonioscope lens and get a good look in the back. Well, how do we assess the optic nerve anyway? I mean, there's a notion that there's an optic nerve that looks more or less normal, and that includes not only more or less the remaining tissue, the isn't rule, but it's also dependent on how large the scleral canal is. And I think the question we often faced before the advent of spectral domain OCT was, is this a big, middle, or small disc? And to George Spaeth's credit should be the notion that a small cup and a small disc may actually be glaucomatous, and a big cup and a big disc, as suggested by Doug, could be completely normal. This is a very complex, very difficult to read, and largely not clinically applicable article by Dr. Spaeth, in which he asked people to judge whether glaucomatous damage had taken place using his DDLS, where you would measure the thickness of the thinnest area of the rim and then use that in conjunction with the size of the disc. And he did this based on not measuring with OCT because he didn't have it, but on the basis of what the size was using a biconvex lens. Long story short, I don't think you'll use it for anything, but it does tell us, you know, that you can't look at the size of the cup and infer the health of the neuroretinal rim. So my experience has been largely here in glaucoma with the Cirrus. And it's important to realize that there's a normative database that was used to generate whether something is normal or abnormal. But buried in there are these gray bars, and I really didn't know what they meant. It means that if the disc area is bigger than 2.5 square millimeters or less than 133, or if the vertical or average cup to disc ratio is below 0.25, they don't have enough in a database to conclude whether it's abnormal or normal. So cutting to the sort of where we're at now, I think this is more or less what I would consider the state of the art, at least for me. You would have gonioscopy with respect to imaging, having an OCT of the RNFL, as well as GCIPL, and then baseline visual fields. This is not the patient I described. I'm talking about someone who is a suspect, or perhaps more classically referred to as just an ocular hypertensive. Let me show you an example of what I think is a problem in looking at either structure or function. This happens to be an individual who is a healthcare provider of animals with a special interest in eye care. She came for an opinion. She's 20/15 in each eye. She's essentially plano. She has skinny corneas. She was already started on topical prostaglandin. And I think it's pretty obvious looking at the right eye that there is a linear streak-like defect corresponding to where RNFL is lost. This was her temporal domain OCT in 2008. And curiously, up top, and this is an early version, you'll see it looks like there is superior thinning of RNFL, but there doesn't seem to be anything inferotemporally where we see that streak-like defect. So here she was. She had what was considered to be at the time the most sensitive visual field test, and that was a shortwave perimetry. Both of them in 2008 and 2009 were normal. So she came back in 2 years, and there in that same location is a quote, Grant's hemorrhage. And we did, and this again is a very early spectral domain, but showing very clearly is that little red stripe at 7 o'clock. And if you look at her printout at the bottom, there's focal neural retinal rim thinning infratemporally. So we did visual fields on her, and these were white on white, not swap. And finally, in 2011, there was a single point depressed. So does she have glaucoma? Does she have optic nerve injury? Well, yes. Is intraocular pressure a role in that? I think that's a question that still remains to be answered. You know, things must make sense. This is another patient who is an ocular hypertensive. She came in, she had a nerve fiber layer that looked great, and her GCIPL came back and it was like, whoa, well, this doesn't make any sense in that middle image. It's like, what's happened? How could things be so askew? So it was repeated and it was normal. Structure and function must make sense. They must fit. Her visual fields were, she had some, a few scattered depressed points. Clearly they were normal. This is an example of someone who has, quote, normal tension glaucoma in a very small disc. And if you look under the left eye, you will see all of those are grayed out because there is such a small central, a small scleral canal at 1.25. So trying to follow him and to see if things are worse by looking at structure doesn't make much sense. You look at a visual field and you get a completely different story. He is doing remarkably worse, notwithstanding care here by me. This is another patient. He's an 80-year-old, and it's pretty clear if you look at his RNFL, there's intratemporal thinning. His GCIPL shows corresponding thinning where you would expect that to fit. And here, his visual fields, yes, I know there's a lens rim artifact, but if you look in the left eye, superinasally, he has a corresponding nasal step, a nasal depression. So sorting through the weeds in him, he does have glaucoma. He does have early field loss, notwithstanding his technically, shall we say, less than optimal visual fields. In conclusion, then, glaucoma management's tough. In my experience, there's not a time I go to clinic and I'm not telling, or I've not told the residents or fellows that I'm humbled every day by a disease that I only completely understand. There are no quick fixes, despite our ongoing love affair with numbers and grids and greens and normative databases. You still have to think. In the end, things must make sense. And it's not structure or function. but structure and function. Thank you.
Questions? I have questions.
Okay.
And I hope you do too, about this remarkable lecture. I'm a fan of good old fashioned photography. I'm one of the people who negotiated the contract with MIT.
Use a microphone.
Yes. Sorry, I'll sit down.
You can pull it out if you want to stand.
So some people have told me that they have abandoned photography, not so much because they didn't know what to do with it, but because it wasn't accessible enough to get to quickly and efficiently in making their decisions, therapeutic decisions, diagnostic decisions. Is that your experience? Is that what has stood in the way of using simple photography?
I must be honest that as it became more difficult to get reliable disc photography, I've moved to RNFL, particularly with the advent of spectral domain for both GCIPL and RNFL. It seems to me that, you know, they're complementary,
You want me to bring you a microphone?
but the notion that you can get the same kind of quantitative data from the disc is just not the case with the photography. You know, I have to tell you that the RNFL or that the OCTs are not particularly good at picking up disc hemorrhages. Like that's not part of their program. So I think we're going to hear from Doug in just a minute. Nope. Okay. All right.
You know, one of the issues has really become economics, that you know, the patient is dilated and you do your imaging, which is kind of the standard RNFL GCC, but then even though you would like to get a fundus photograph, you're not getting paid for it. So you have to pick and choose. And it's gotten to the point now that reimbursement for the fundus photograph is probably more than what the OCT is. But you know, to your point, Rich, invariably you look back and you always wish you had the fundus photo at some point in time to compare. And then, you know, maybe a couple of years before you say, you know what, I should have got it, or I'm going to do it this time. But it's picking and choose how you want to get paid for it. I think that's really become the limiting factor.
I think if I could suggest what would be optimum treatment, patients will come in at time zero. They would have the very best, whether that's Topcon or whoever, image, a photograph taken. It would remain there forever. And when you thought there was a change, you'd say, oh, let me go back. Oh yeah, 2008. It's obvious there's been a change. So I think best of all worlds, having one outstanding, you know, razor sharp photograph is a great value.
And some of the OCTs can give you that in parallel. It's just that the emphasis has not been there.
That's right. Yeah.
Okay.
I think you got
So now there are devices that you can use with a cell phone camera. Once somebody is dilated, it'd be pretty easy to get a very high number of pixel photograph. You think that might come back? I know that Felipe Medeiros has been using photographs and has used artificial intelligence to be able to tell the difference between, you know, whether somebody is damaged or not. And there may be services that will be set up where you can just take a cell phone photograph and have it looked at by somebody who's got an artificial intelligence system set up. That may be something coming in the future.
I think that's a brilliant idea,
And
Paul.
particularly in third world where you're not going to buy $100,000 machines.
I guess anytime we deal in this country, and I'm sure in Canada, the rules are the same with respect to PHI protected health information. You take a picture of somebody on your cell phone, that has just become a medical record. And there are ways to assure, as the plastics people do here, when they take a photograph of a lid lesion, then they can send it from their phone to Epic, no questions. But we just need to be very mindful of the fact that something as innocuous as taking a picture of a disc is a different issue. I have to tell you that I wrote an editorial, and it was, if we're going to publish pictures of retinal images and have blood vessels, should we ask consent of the patient? Because the retinal vascular pattern is as identifiable as your fingerprint. I said, who the heck's going to do that? Well, no, but the potential does exist. So it's something to consider.
I have a question. I have a question for you about frequency of your OCT. So as part of our polling, there's a little bit of discrepancy. Would you mind discussing what your protocol is for how often you repeat those OCTs in that initial glaucoma suspect patient?
Gee, if somebody comes in with a pressure of fill in the blank 20 or 21, and they have normal corneal thickness, and there's an OCT that looks normal and their field is normal, and I see them back and the pressure remains the same, and the disc, as best I can tell, does not show any change. There's no suggestion of focal thinning. Although I can tell you how many times I have missed what is obvious change in the RNFL because I couldn't see it. There wasn't cumulatively enough. I think I would probably repeat it every year, year and a half, until I was certain there wasn't any change, and then I would try to stretch it out.
And in that same patient, though, that you just made a diagnosis of glaucoma, how frequently? Is it different?
I think it depends on, if somebody starts with a pressure of 38 or something and it's brought down to 26, I'm a lot more worried about them progressing than somebody who has early change with a pressure of 23 or 4 and a normal corneal thickness, and now the pressure is 16. So I think it really is individualized.
Douglas.
I think we could use the same rule similar to what's done in visual fields. You need to have a good baseline. So a single OCT or a single visual field is probably not good enough because there's some variation from one to another. So get 2, maybe 3. The second thing to take into account is that it takes a while for progression to occur. So that, for instance, if you're trying to see whether or not your grass is growing in your yard, if you come back 15 minutes later and measure the blade of grass again, why, it's not going to be changing, even if it is growing. You have to give it enough time. And it's generally considered that 2 years is about the soonest that you might be able to detect progression. So 2 at baseline, and then another one at 2 years, maybe a second one at 2 years, especially if there's any doubt about whether it matches the initial one. So, and if there seems to be rapid progression, that's your clue that from here on out, you're going to have to do it more frequently than that. But doing it at 1 year, at least in visual fields, is too soon. 2 years is okay. And that's for somebody who's losing 2 decibels per year in visual field terms.
And I can bore you silly with the discussion of the mathematics of that. The progression detection algorithms are not specific enough to meet the requirements if you only have 1 OCT. You'll run off into the weeds with false positives that you can't deal with. If you use 2, and if you require that progression be detected 1 baseline versus follow-up and the second baseline versus follow-up, your specificity rises significantly. And that's something that Doug learned and taught us in the normal intention glaucoma study. So yes, 2 baselines.
Do you do them on the same day?
I
mean, we get 3 here usually.
yeah.
3 OCTs, not 3 fields.
OCT.
All right. I'll sit down and shut up. Okay. So it's not the first time that Elizabeth has told me to sit down and shut up.
I just want to make 2 quick comments. That was Rich, great presentation filled with a ton of gold and pearls and important information. And 2 quick comments, one on progression, one on documentation. The progression is we have a prospective study. Many sites have many prospective studies with structure and function. And if you carefully characterize structure and function in a systematic way and do your testing frequently, I've actually got a number of patients now with really well-documented progression at 16 months in both structure and function and optic nerve changes. And it's really remarkable. If you were to do a field once a year, it would take you 5 years to see change. And economics are important, but you have to also understand the practicality. If you can't tell whether a person is getting worse until your 5th visit 5 years later, that's a real problem. The second is in terms of documentation, and I'll make another plug for disc photography. Technologies change, they get better, they evolve, and they're not always backwards compatible. An optic nerve photograph will be readily available. You'll be able to see it. And I think if everybody had a photograph of their nerve before they graduated high school and they kept it on their cell phone or on their computer and they had that available, it would be remarkably useful and powerful to tell and differentiate a physiologic large disc from a real suspect and somebody that's probably been unnecessarily treated for decades. So aside from the pallor, the hemorrhage, the peripapillary atrophy, the disc hemorrhages, all of which you can only see on a good high quality photograph, whether it's stereoscopic or not, the photographs for me are really impeccably powerful.
David brings up a good point about backwards compatibility. I mean, we all went through the issue years ago when Zeiss went from the Stratus to the Cirrus, and we were very upset that they blew off those, all that data. I had a phone call yesterday, and I get these all the time from an optometrist asking their OCT is now run its life course, and what was my recommendation? And one of my recommendations was a different device than what the person had. Then, and he has like 7-8 years. Then the question is, well, how can I just blow off all of my patient data? Because right now, so when we talk about backward compatibility, it's even between, devices, just to change. If you don't stay with the same manufacturer right now, the data is not compatible. And as long as we've talked about standards, we've asked, it hasn't happened. So, I mean, there's a lot of issues there.
Thanks.
I'd like to second what David Greenfield said. I think that particularly teenagers going off to college and they're getting an exam and you find a large physiologic cup and somebody says, oh my, they must have glaucoma, and sends them for, I recognize it as a large physiologic cup. Immediately get photographs, good quality, make sure they're good quality, and tell them to keep them wherever they keep their important papers like their passport. And because 40 years later, somebody's going to want to look, and I think David is exactly right. That's the one thing that is an image that will always be useful in the future. Nobody takes the original, right? Make a copy.
There you go.
Make a copy. Yep.
Last question.
More of a comment. Again, great presentation, and thank you. I would like to also encourage the use of disc photos because I think it also forces the doctor to look at the disc better. And we're in a time where there's a lot of reliance on imaging and speed, and is the number different? And the machine isn't going to think for you. And I think particularly for the educators in the room to impart the importance of actually looking at the disc critically can't be overstated. So thank you.
Rich, thank you so very much.
Pleasure. Thank you.
Years ago, this society, Optometric Glaucoma Society, received from Doug a classic education over the course of a couple hours in optic nerve evaluation. It was so significant that we've asked him to repeat it. And I give you Douglas Anderson.
Okay, it's not going to be. What I'm about to present, which will be pre-recorded, is not exactly a repeat of then because we don't have as much time. But what I will do is to show you what I think about examining the disc, and then we can discuss some things afterwards.
Thank you. Roll it.
Good morning. This morning, we're going to talk about how to examine the optic disc and some of the features of that. And so let's get into it. For this presentation, you'll need some special glasses that have been supplied to you that have a red lens over the left eye and a blue lens over the right eye. And in addition to that, you have to be capable of binocular stereoscopic vision. Be careful with the with the glasses. Don't put your finger and thumb on the lenses because that'll smudge them, and you'll be putting them on and off a couple of times during the presentation. You can put them on now if you like, get them all adjusted and ready, and we'll go. We're going to look at the methods to examine the optic disc, starting with binocular indirect ophthalmoscopy, which is familiar to us. It's an excellent method for examining the retina and the details of everything, and is something clinically very useful, but probably the worst method for evaluating the optic disc with reference to glaucoma. The reason for that is that the image is too small and there's not enough stereopsis. It's much better to use a handheld lens. It's also an indirect lens, and combine it with a slit lamp where you can get more magnification even. And to get the greatest magnification, you should use the 60 diopter or the 78 diopter lens rather than the 90 diopter lens. Not only does it give you greater magnification, but it gives you better stereopsis, because the axial magnification is the square of the transverse magnification. That means if you are looking at a cube that is 1 centimeter in all directions, and you use a lens to look at it with 2x magnification, it will be on its face 2 centimeters by 2 centimeters, but in the distance going away from you, it will be 4 centimeters, and it will exaggerate that axial dimension. The Ruby lens does exactly the same thing, except that it uses a minus lens instead of a plus lens. And that gives the same magnification as a 55 diopter plus lens would, except that the image is not inverted. And you can look at it with the slit lamp and give it even more magnification as you need. The best way to look at the fundus is with a contact lens, Goldman fundus contact lens, but it is a little bit clumsier to use. It requires putting goo on the cornea, which may make it difficult to get photographs later on. And so you use that when you really need to have a better view. You can also examine stereo pair photographs, and that's a good way to look at them too. The disadvantage compared to the slit lamp method is that you don't have the slit beam to use, which you can use to profit at the slit lamp in order to move the slit across the disc and so on, and get another way to evaluate its three-dimensionality in addition to the stereopsis. At this time, if you would, please take off the glasses carefully, don't smudge the lens, and we'll use them again in just a minute or two. We may do this a couple of times through the presentation. Now here, without stereopsis, you can see physiologic cups. What one can see is that the nerve fibers come from the different regions of the retina, and they enter an opening in the sclera, where they then proceed out the back of the eye, forming the optic nerve. And there is a nice little sleeve going around the exit canal. It's represented in white here. And what's left over after the nerve fibers occupy a certain portion of the disc is a cup in the center. And the larger the disc is, with the same number of nerve fibers coming in, the larger the cup is in the middle. And that's just normal physiology. That's the normal anatomy of the optic disc. And the size of the cup depends simply on the size of the disc itself. Now, in glaucoma, what happens is that there's a sectoral decrease in the number of nerve fibers. And so while there are a good number of nerve fibers entering down here, up at the top, we can see that there aren't as many nerve fibers. And so therefore, in the top sector of the disc, it's a little bit thinner than it is in the other sectors. And that is the predominant basis for recognizing early glaucomatous cupping. It's recognized by the absence of the amount of tissue here. And the rule is that in a physiologic cup, the inferior sector has the most nerve fibers. Next is the superior sector, but that's violated in this picture. The superior sector is not the place where there's the most abundant nerve fibers. Then comes nasal, and then comes temporal. And that's the rule. Inferior, superior, nasal, temporal is ISNT. That should be the sequence, and it's violated here because the inferior is not the second most abundant, the superior is not the second most abundant sector. And to go along with that, there are defects in the visual field seen in the inferior sector of the field, corresponding to this retinal region. It's a Goldman field in use at the time that this was discovered, that was the sign of glaucoma. And but these darkened areas are areas where there is diminished vision. And you can see the difference here, can't you? And here is a disc where there's an abundant amount of tissue in all sectors. And here, there's a good amount in these sectors, but a deficient amount in the superior sector. And it's the second one, inferior, superior, nasal, temporal. So it should be the second most abundant, and it's not. So can you tell the difference between a normal configuration and a glaucomatous configuration? It's almost as simple as that. Well, not quite. We're going to see some places where we have trouble determining whether that's so or not, but that is the difference. To go through and just to recheck ourselves on the anatomy, what's happening is that the retina is here. And there's nerve fibers. They're all coming together toward the disc. And so they are thicker in amount at the disc, and it's harder to see. It's harder to see through this to see the disc and the edge of the disc, but that's the area we're going to be wanting to examine. And you can see the choroid is underneath the retina, and then the sclera, which comes and joins the dura mater. And across the nerve, as it exits, and just before it gets its myelin and turns into white tissue instead of gray matter, the lamina cribrosa goes across, and there are holes in it. You know that. I want to point out the flange of scleral tissue that goes around this exit canal. It comes up and in most cases separates the choroid from the disc. And you see that when you look in, you see it as a white stripe around the disc. Here you go. Here you have the disc tissue and so on, and there's the white stripe. And it's an important landmark because all the judgment about the nerve tissue, when it's looked end on like this, is going to be judged from the inside of this ring of white. Here it is in a larger disc where you can see the inside of that. That is the real disc margin, so to speak, is the inside of that white ring. And your judgment about the tissue being present is the diameter or the radius from that point. This demonstrates the isn't rule. Inferior first, superior next, nasal next, and temporal next. And in a larger disc, again, inferior, superior, nasal, and temporal. This is an illustration of the entire field of view, and it is shown only to emphasize that there is a mounding of the tissue in the region of the optic disc and making it more difficult to see the details at the edge of the disc. And we'll see some examples of that. In fact, in this particular one, although you can't quite tell, the pigment epithelium comes in and covers part of the choroid, and we're going to see what that's about. Here, the pigment epithelium is coming along. And when it gets to the end of Brooks membrane, it makes a turn back and then continues as the neural retina. Here's where the photoreceptors start. And so we have this area of deep pigment just ahead of the disc margin. Here's the scleral flange right there. And when you see it ophthalmoscopically, it's like this bottom photograph. It's around the disc and around, look carefully. Here is the white rim around the disc, and the disc tissue starts inside that white rim. Not very pink, it's not very darkly colored in this, its contrast isn't right. But anyway, there's an anatomic variation, and that's the point of this. There are some humongous anatomic variations with a tilted disc. And here, if you look down with an ophthalmoscope, you will see the sclera, and you'll see the choroid, and then you'll begin to see some of the layers of the retina, and there'll be a rim of anomalous tissue that you see surrounding the disc. Okay, now is the time to put your glasses back on with the red lens over the left eye. See, lens is misspelled. Sorry about that. Put the red one over the left eye, and we're ready to go. And here you can see a physiologic cup in stereo. And prominently, you can see the rim around the tissue, and you can see the disc tissue itself around the circumference. And as always, the inferior one is larger than the superior one, which is larger in turn than the nasal one. And the temporal one here, it's a little slanted, and so you don't, but it's not as abundant as nasally. And so there we go. And here's again another normal disc. We get tired of that after a while. But here we notice something different. Superiorly, the tissue that's here is a little bit sparse, not quite as much as there is down below, or nasally, or temporally. There's thinning of the rim of tissue here, remembering to count only from the inside of the scleral rim. And right here, it's just not very much compared to inferiorly down here. And that's a sign of early clinical. That's it. Is that you can see that there's more tissue above and below than in the right side after it has progressed. Same disc seen some months later or years even. And now you can see that there's not as much tissue. The tissue has disappeared from down below, and it's excavated. And up above, it's excavated in comparison to the before picture. It's subtle, but it helps to look at the other eye and see that they're not the same. Now, sometimes there's a tilted exit of the optic nerve. So this is a time domain OCT, not very modern. But the nerve fiber layer is coming and then leaving the eye in an oblique fashion. And from the other side, from below, it comes and it leaves the eye obliquely. And when we look at that ophthalmoscopically, we can see that the nerve goes around, but that from below, the nerve goes straight in. And it's actually a little hard to tell where the scleral lip is. Makes it very difficult to evaluate this sector of the disc. But the thing is that when nerve fibers disappear, looking at the OCT diagram from here, what happens is that the side of the cup moves outward. When nerve fibers disappear from this side or the bottom, actually what happens is that the cup goes backward more than it expands outward. And so to judge this disc, we have to be thinking in our mind, not what this direction, but in the direction toward you and away from you, as to whether or not that is getting thinner. And that's what makes it difficult to evaluate a disc where the exit is oblique. Is the other eye, same patient. Here's another, this is a non-glaucomatous disc that has a tilt. And you see the vessels tending to not go through the center, but going instead to the bending around and going beneath our field of view, whereas the fibers that are coming here are coming in and just going in a flat plane and exiting also to the upper left. And it's judging the thinness of this area is difficult because the sitting goes away from you. Fortunately, what happens is that when doing so, it becomes pale in addition to excavating. And then you can tell that sometimes and see kind of a pale extension of the cup in a vertical direction, and that's a key marker. Well, sometimes it's just almost hopeless. There is so much sloping that the vessel's going around there. And here, oh, the nerve tissue is kind of a broad thing here. And how could you ever tell that it's moving away from you and backwards? Well, the only clue is going to be pallor. You can see that there is some loss of some coloration in the tissue in the lower temporal quadrant, and the actual bottom of the cup is way over here. And so maybe there's the same amount of tissue. Very difficult to judge. So the beginning of tissue loss is at the inferior portion of the optic nerve in this particular example, and the inferior sector has a certain width, and the cup becomes taller than it is wide. And that sometimes is a way to kind of get your first clue. The evaluation should really be of the thickness of the rim, but you can get your first clue by noticing that the cup is vertically oval, and that would be true here. Here there's thinning down in the lower temporal quadrant, and so the bottom of the cup actually looks oval and in a vertical direction. If you lift up your glasses momentarily, you can see the shape of the white cup in monovision. And it is taller than it is wide. Okay, put the glasses back down. But the stereopsis does enhance your ability to evaluate that there's kind of a excavation down here. It's like there's a nest that's been created for something that's shaped like a football rather than a square spherical ball. Another instance of early glaucoma. It's kind of thin up here on the upper temporal side. Compared to elsewhere. So it's localized cupping, usually above, but sometimes upper temporal or lower temporal. And as we'll see sometimes elsewhere. But this disc did go on and progress. And so now it's much more evident that the poles of the disc superiorly and inferiorly are excavated more than the other poles of the disc. Another disc where it's thinner up above than it is below. And it progressed over 96 months. Here's one where the excavation is localized more nasally than in other sectors. So, yeah, I guess the isn't rule is violated because the temporal rim is smaller than the nasal rim rather is smaller than the temporal rim. But the excavation, the localized loss is placed nasally, and that's a variation. So the real rule is localized loss of nerve fibers, usually superiorly and inferiorly, but can be any sector. And that's glaucoma. So this one and the field loss will be different. So here's a case of early disturbance nasally. So what do you think about this disc? Give you a minute or so to look at it. If there's any problem here, well, pretty good, healthy rim. Well, when you look at it in stereopsis, you come to appreciate that there is really an excavation down here inferiorly. And that's where the stereopsis comes in. It wasn't so obvious when you were looking at it in the monocular view, which is the one on the left. The stereoscopic view does help you to recognize this. And that's the importance of using, not using the direct ophthalmoscope, for example, but using a binocular view. This particular case, you can come to believe if you realize from your records that there was a splinter hemorrhage down inferiorly 5 years earlier than the photograph shown. And if we compare it to the other eye and realize that they're different. All right, what do you think about this one? You got it? Okay, well, this is an example of a vertical extension of a white stripe away from in the bottom of the disc. And actually the excavation goes down all the way to the bottom. And it's more that it appears white than it does excavated, because it's a sloped disc. You see the vessels are leaving way over here, and this disc is sloped. And because it's sloped, you're looking down on the face of the tissue that's exiting the eye, and you don't get so much a stereoscopic clue, but the pallor tells you. And now that you look at it, you can see the rim, you see ending and just disappearing down there. And along with that, field loss. So let's go on to another instance here. Oh, what do we have here? We have a disc where we can see the scleral rim and follow it around, and it goes, I guess, around here. Huh? going here. I guess that's it. And then over here on the other side of that rim, we see reduplicated pigment epithelium, which we're used to seeing here. We see some right up here at that top of the disc. So there we are. And the rim is a little bit thick, the scleral rim. But what is this pigmented tissue inside the rim? That's a strange thing. And what it is it's uveal tissue that is coming underneath this distorted disc, underneath the retina, over the scleral rim, and under the nerve fibers that are exiting through this tilted disc. And it shows up as a pigmented crescent described by Bruce Shields. It's called a Shields crescent. And it's different from the pigment epithelium crescent as seen here. And it's underneath the nerve fibers. It's just an anatomic variant. But remember that we have to evaluate the rim tissue from the interior of the scleral lip into here, not from out here and not from inside the gray crescent either. The gray crescent is actually part of the innards of the disc. And this is a tilted disc, and so it's hard. This is the flat side, and this is the humped up side. And so it's difficult to evaluate. You need to recognize this anomaly. This is another example of the same thing. And yet another. Sometimes things are so messed up that you really just can't quite tell what's going on. I mean, here is the scleral rim, obviously, I guess, obvious. And then a gray crescent inside of it. Oh, and here, this would be the end of the pigment epithelium, doubled over. We're used to seeing that. There's a sample of it up here too. And then what is this line? I don't know. This particular photo has been passed around among some glaucoma specialists, and everyone is kind of puzzled at that. Maybe that's where the photoreceptors end or something like that. But anyway, sometimes you can't quite evaluate things, but with regard to glaucoma, we can, again, look at the rim tissue inside the scleral lip. And in this case, you have to recognize that the scleral lip is going out to here in order to evaluate this sector. And it actually doesn't look bad. And if you need to, you need to go and do an OCT or do a visual field and see that actually this disc is not affected by glaucoma, and not take it that it's excavated to the rim here, falsely assuming that this is the rim, when in fact the rim is out here. And another instance, it's difficult to judge, isn't it? Now, sometimes there's an anomaly all the way around the disc. And what's happened here is that the pigment epithelium has ended before reaching the disc. And you can see right down onto the choroid, which is hidden by the pigment epithelium elsewhere. But here you can look right down on the choroid. And there you see the dense scleral ring is obvious. And this has sometimes been thought to be what's called a glaucomatous halo. And it's called peripapillary atrophy because it's assumed that it was previously present and it atrophied away. It disappeared. That is probably false. People are probably born with an anomaly like this. And the thing is, though, that they are more sensitive to pressure and the effects of pressure because the choroid doesn't nourish the nerve fibers that are going across this space where there's no pigment epithelium protecting it from the choroid. And as it goes across the space, it's going to disappear and be damaged. And so many discs are completely excavated and have this halo. And it's assumed that the halo resulted from the glaucoma. And while it is true that people that have some disturbance of the pigment epithelium around the disc, it can enlarge over time in a glaucomatous patient, sometimes in normal patients. It's probably not true that it all resulted from glaucomatous damage. There are plenty of examples of people that have halos. But with the exposure to the choroid, the nerve fibers are susceptible to damage. And so they easily can get glaucoma, even normal tension glaucoma, and look like that. Sometimes it's not in a ring, but it's just as a sector. Here you can clearly see the end of the pigment epithelium, and it's doubled over. And that's not the kind of thing that would happen from atrophy. So this is an area of the, there's the scleral rim. There's an area of choroid that's been bared, and it's a tilted disc. And this is actually called an inferior conus. Frequent that this sector of the disc becomes excavated because the nerve fibers are subject to disturbance when it goes over the bare choroid, or at least that's my idea of it. Okay, in the time that we have left, I think I'll just run through a number of examples. It might be a little bit repetitive, and we'll just go as fast as we can here. Here's an example of one that's clearly glaucomatous. There's a glaucomatous halo that we talked about. There's splinter hemorrhage on the nasal side of the disc. The cup goes all the way down to the rim here at the bottom and all the way up to the top, and you wouldn't have any trouble recognizing that as being glaucomatous. This is another one where there's clearly almost a notch. And by the way, this type is oftentimes associated with dysregulation, is to have very localized loss, almost like a pit that goes. Here's one that's not quite so prominent, but similar in that it goes down to the bottom and right over here, almost to the rim. See, the scleral rim is where? Right here. And it comes down there. And so that's close to the previous one in terms of its general shape. The white spot is sort of like a teardrop. Oh, here's one where, again, there's a deficiency of rim tissue right up to the scleral rim. See, and you see the scleral rim. This is not the edge of the disc up here, but right there where you see it. And clearly there's a verticality to that. Let's see. Now we have here side by side two examples. I think you could recognize this one quite easily as being normal. And this one quite easily being similar, but having an excavation down here, even without your stereo glasses, which by the way, you don't need for these. These are not in stereo. So I think now you can tell the difference between glaucoma and normal. And I think here you see glaucoma on the left and normal on the right. It's almost, you just take a quick look and all of a sudden they just don't look the same. And similarly here, that looked like a glaucomatous disc to you. Maybe before today it might have, because the cup disc ratio is so large. And people take that to mean it must be glaucoma, but this is clearly not. You can see the abundant tissue inferiorly and superiorly as well. And then nasally and then temporally, the isn't rule serves you well. right there. So does anybody have any questions?
Well, I hope that demonstrated what I meant to demonstrate, and I'm sorry that I'm not physically able to stand long enough to give the lecture at the podium, but we can take any questions. Before we do that, let me just summarize the main points in less than a minute. To examine the disc, the best way is with a magnified stereo view with a slit beam if possible. Cup disc ratio, there is no longer a sign of glaucoma. You can have a cup disc ratio any size you want and still be physiologic or glaucomatous. Instead, you need to look for local loss of tissue at the rim. And then we looked at some anomalous discs and how they can be tilted or have some variation in pigmentation or other anatomic variations, but how the isn't rule still holds and can be seen in most cases, though some are very difficult to recognize. And the final point had to do with halos and crescents. We usually think of that and call it peripapillary atrophy, but I think the evidence is that really many people are born with an anomaly such that the different layers don't line up properly and so on. And so that you have an area of visible choroid or even visible sclera surrounding the disc. If you follow over a period of time, there may be some enlargement of that area in normals as well as in glaucoma, maybe more frequently in glaucoma. But the fundamental presence of a halo doesn't signify that there's been acquired damage to the nerve fiber. What it signifies is that the person may be susceptible. And it's been noted, for example, that in the sector that has a crescent, that's the sector where the nerve fiber layer is often deficient, and the field loss is consistent with that. And that's why it was originally thought to be atrophy, but it really isn't. I think those were the main points that came from this, and we'll entertain questions.
I have a question. With this point of view, would you say that you find the correlation between structure and function improved over what we see in the literature? I imagine it's still imperfect.
Yeah,
in your hands.
I mean, with regard to location, it's pretty good. With regard to how bad the field defect is or what threshold changes in particular, I don't see that we can judge that exactly.
Yeah, but it's important that location is
location should correspond so that if you have a distinct notch inferiorly, and we saw one example of that anyway, why it should have an upper arcuate defect to correspond.
Yes, and I'm thinking of a 2019 paper out of Anders Hale in which they required structure or repeat fields as before calling a visual field abnormal, and that drastically improved the sensitivity and specificity of that analysis.
Yes, obviously there's a subjective component to this, and it's not quantified. And so, yes, there has to be confirmation somehow.
Paul.
Or should be.
I think Elizabeth Hodap may want to comment on this too. We were the disc readers for change at the 20 years. And I seem to see the patients who got peripapillary atrophy increasing, that there seemed to be a correlation with people developing cupping in that area, that it at least should make you pay a little more attention to it and be suspicious that there was change. I don't know if Elizabeth wants to comment on that. And also, you had a paper one time saying that in ocular hypertension, in a bunch of photographs that you saw half as many halos as in the normal population, and that in primary open-angle glaucoma, you saw about twice as many in normal tension range glaucoma that you
I
saw
don't
about 4
think
times as
I
many.
wrote or was on such a paper. I think that must be someone else, but yes, one of the aspects of being a reader of the Oates study at 20 years was we were forced to look carefully at stereo images and answer specific questions as opposed to just sort of look at them and say, is this better or is this worse? We had to comment on peripapillary atrophy, and I was really struck by the number of patients whose nerves had had a change. And yes, it was often associated with a change in the rim, but that was not something I had thought about until I was actually forced to say yes or no and say where.
One of the things that can fool you about the progression of the rim, or the halo rather, of the crescent, is that as the nerve fibers diminish, the visibility of the tissues underneath improves. We noted early on in the lecture that there's a humped up amount of tissue. And as that tissue becomes thinner, the halo becomes more conspicuous. And I think some of the early descriptions of there being progression in the halo and crescent were that it became more conspicuous, not that it enlarged. And we showed that in cases of unilateral severe glaucoma that was total, and you could superimpose the before and after. You would see that the extent of the halo is the same as it was. It was just that it was more obvious.
And it really was that it was very distinct areas where it wasn't just that it was more marked, more obvious now. The extent really changed. And so I'm kind of wondering, when the ocular hypertension study, I don't know if Rich Parrish is here, looked at that, is there going to be a paper coming out? Because, obviously she and I saw this and commented to each other that we were struck by this because it's not something we had thought of clinically before. And look forward to some formal analysis after it's looked at by the final endpoint committee.
Well, actually, that has been published. The ocular hypertension treatment study published so many papers that it's kind of lost among there, but there was one specifically with regard to the crescents and how they changed 20 years. Yep. And it's, there is a publication. I would have to get the reference for you, but there is a publication on that. And it showed that there was some change in becoming more conspicuous. There were a few instances of enlargement of the area, but not much, not as much as you might think.
David.
So I find mnemonics to be very powerful in helping you to remember things in a very simplistic way. And Doug, when you summarized, which was extremely helpful at the end, the important take-home messages about looking at the disc. Somebody once had I think it was Allergan, an educational program called the Forge series 20 years ago that had nothing to do with product, but it was a group of people I was involved with. We had an educational series about how to look at the optic nerve, and the mnemonic came about called the 5 R's. Some of you may be familiar with it, some of you may not. You can Google it, you could probably find the series. But the 5 R's for disc examination, all of which were really emphasized beautifully, Doug, in your presentation, in your summary, going from outward in refer to, let's see, retinal nerve fiber layer, which you can see on a photograph, the R, the region of peripapillary atrophy, the ring, which really helps delineate the size of the disc, the rim, obviously being really critical. And then the last, and I'm trying to figure out where the R comes from, is the disc hemorrhage, but maybe an RNFL hemorrhage. Can't remember where that R fits in. So you might have 4 R's plus, but I find it very helpful.
Red
Your-
streak or something.
red streak, but even if you remember 3, if not all 5, a nice way to kind of just conceptualize when you look at a disc in a very comprehensive way, you should try to focus on all those elements.
Other questions?
There was, I think one of the things that showed toward the end was the 2 discs, one being non-glaucomatous and the other being glaucomatous. And the point that I wanted to make with that is that after studying all of these different variations, instantly, when you look at those 2 discs, you say, that one's glaucomatous, that one's normal. It's almost, after you've analyzed it and looked at so many, which is why I try to show a lot of examples, it's instantly obvious. And it just like the rabbit and the cat, you don't have to analyze anything. It just looks different.
Do you think there's sufficient time for typical ophthalmologists and optometrists to examine in the course of clinical care? Or is this something that's best done in clinical trials?
To examine the discs?
Detailed examination of the disc.
I would hope that it would take 60 seconds per eye.
Well, it takes you 60 seconds. And maybe it takes David 60 seconds.
But look at the 2 that I showed. That was instant recognition, I think.
I think so too. And that's why I've tried to follow in your footsteps and actually look at enough of them so that it starts becoming a cat versus a rabbit.
Yeah, I can remember one day looking at a visual field and deciding that it was a lens rim artifact and not an arcuate scotoma. And saying that should have been obvious. So I went over to Elizabeth Hodat and I opened up the chart and closed it. She had about a half-second view and she said, that's a lens rim artifact. If you once understand it, you don't need a lot of time.
I always give Elizabeth equal time.
I'm not disagreeing, but you can, I think, what you really want is to learn the vast majority of the ones that are easy to get right away. Like that's glaucoma, that's not glaucoma, so that you know which ones you have to look at because you don't have time to do a terribly careful search of everything. But if you can just get rid of 90 or 94% of the patients because it's normal or it's not, that's big savings.
Yeah, Doug and I frequently would sit down and look at something and spend several minutes discussing it and show it to Elizabeth. And within 10 seconds, she made an answer. I think her central processing unit works faster than ours.
It's always been faster than mine, I'll tell you.
Well, that's partly true, but I think that it's also true that all of us here can recognize certain things instantly.
Yes.
When you see a rabbit, you know it's a rabbit.
That's my point. That this is a skill which will vastly expand capabilities in the clinic, and it takes time. It takes real time to get this.
So, kind of like the what's left unsaid is the problem that has surfaced, and at least I can mention for optometric education, and the fact that students and residents just no longer value examining the optic nerve, and that it's become an OCT world. And I think one of the messages to take back, because one of the reasons why, at least, I've always looked at this forum as being important is, for hopefully the folks in this group can try to influence, the people that they educate, because it's, it's a problem, and I don't believe it's just in optometry. I think it's in ophthalmology too. But it's I know here we're probably preaching to the choir, but it's, I mean, I recently ran into an issue with my wife where she went to get an eye exam and the optometrist, did an OCT and, and she at one time was about a -9 myope. And she had LASIK years ago. And, she has a very healthy nerve, but she has, as Doug described, one of those gray crescents and a tilted type disc. And when you do an OCT, it's nerve fiber layer loss. And bingo, everything pops up and just didn't, person just didn't look at the nerve. But that's something that I see with students and residents. So, I mean, that's just a message. Hopefully you can come back that looking at the nerve, I think you've heard that with fundus photograph really is important.
The data I remember says that 20% of OCT images have disabling artifacts. 20%. It's not unusual.
Yeah. Now, the question comes up about education. How do you go about educating your students and residents in this matter? Because as you see, it was a very complex stereo presentation here. And that, how are you going to do that when you go back home? You're going to show patients and examples and you don't have a collection of slides. Well, I have two potential avenues for you. One is that in addition to recording this lecture, which my daughter helped me with, she also decided to post it on YouTube, which is available to anybody. And the question is, how do I get the link to you? And I don't know the answer to that. But maybe we have to have an email list or something, and then we can send that link and you can watch this lecture, this very lecture on YouTube. You won't have the proper glasses for it perhaps, but you can buy them on Amazon. They're $1 for 100 of them or something.
Murray, thank you. Oh, I'm sorry. Go ahead.
Okay, the second source is I was asked to give a lecture in Poland and they published it. This is not in stereo, but it's instructive and has the same concepts in it. Unfortunately, they published it in a Polish journal. I have a, yeah, yes, that's right. I have a PDF of the paper. I don't know how you get that out either.
So Murray,
that Dr. Greenfield mentioned is also probably still available. I have a copy of it. Maybe he does this too. And that is a very good teaching thing that you and Weinrib and Hemo Susanna put together. And it's very good teaching material.
Murray, I'm glad that you brought this up because this is an educators meeting and we really need to try to, figure out best practices for educating our optometry students. I would love to get the link and I can guarantee you that if we can somehow find the link to this YouTube video, Dr. Anderson, we will send it to everybody who's in attendance at this meeting. Peter Lawley also has a video that's just a huge series of stereoscopic images and he sort of narrates it. I think it's about 30 minutes long. And he has been very generous in making it available. And I don't have the actual information right now, but I know I can get it if you're interested. It's something that students can look at on their cell phone. It's actually really designed to have great stereo disparity on the cell phone size. And so we can get that as well if anybody's interested.
Competition among students with a grand prize.
Well, what you need is a library that everybody can access for several of the reprints that have been mentioned and also the presentations in stereo. Now, therein is a little bit of a problem in that you either have to have side by side, in which case you needed prism glasses, or you use this method, which is anaglyph. And my daughter pointed out that the anaglyph glasses are two varieties, one with the red on the left and one with the red on the right. And the ones that you get at Disney World have the red on the right, and the ones that we passed out today have the red on the left. But for an educational institution, buying a box of 100 of those for $1 is an investment. And then maybe the Optometric Glaucoma Society can create a, yeah, no. No, let me finish. Maybe the Optometric Glaucoma Society can start a place that you can get a link to and download appropriate, a library of various papers and things that are useful. And you can load up.
Bascom Palmer is setting up a website now in which a lot of lectures are being posted, and this would be a good place to put it. And would be very accessible to anybody.
But it can be in more than one place too. Yeah. Yeah.
So I just more of a question, I guess, for the audience as well. I mean, it was easier when I was a student because we had paper charts as a resident as well. So we drew every single nerve. I'm just curious in terms of, as educators, do we guys still do drawing assignments? How do you guys train residents? Do you make them draw nerves? We didn't have CE ratios in the charts. We had drawings. So just kind of curious on how you guys train. Maybe some folks at Bascom, how you guys train as well.
Not really.
I have seen some terrible drawings of discs. I mean, I think for billing purposes, they say, well, if you draw the disc, why you get a higher level of disc exam. And so, and I've seen some that are just kind of two circles like a donut, and that's all it is. And it's not helpful. And right next to it will be a 0.4.
The consistency over time is limited.
It's not the same.
It's also interesting on those that have a drawing and a number to pull out a ruler and see how they match up.
Yeah.
And it's about as good as you think.
But cup disc ratio is so 1950.
We're going to talk about it today.
My takeaway is I see things in photographs that I miss over and over again.
Yeah.
Especially hemorrhages. But if you're drawing it, you're not going to discover something you didn't see the first time. So there's a lot to be said for having a real.
Yeah, the hemorrhages are easy to miss. And I can tell you a story about that. You may know the name of Stephen Drance, who, he's the one who described the disc hemorrhages. And when Ralph Kirsch and I had an exhibit at the Academy meeting about the early glaucomatous changes, because that's about the time that we recognized the vertically oval. And we had a whole series of pictures showing the principles of the vertical direction where it usually starts. And Stephen came over and asked me, he says, well, how come you don't mention hemorrhages? And I said, well, we never really saw any. And he said, well, let me show you. And he walked around our exhibit and showed hemorrhage after hemorrhage after hemorrage on the photographs that we had on display.
After you asked him what's wrong with the water in Vancouver.
Well, Stephen was irritating that way.
I would make a plea for beam splitters and having you examine the patient and in real time, having your student or resident look in at the same time. There simply is no substitute for with the patient in front of you. They're not looking straight ahead. No, you have to focus. It's worth its weight in gold. There was a time when I essentially demanded that this prestigious institution go ahead and put out the money for a beam splitter that fit on a hog stripe, which was, I think, $8,000. The beam splitter and the ocular and the tube, they are very expensive. They are worth their weight in gold. And there's simply, in my opinion, no substitute for these are fantastic, but it really depends on being able to impart what it's like to examine a patient with an imperfect media, with poor fixation. And I think it's something that everyone in every Department of Ophthalmology and School of Optometry should consider investing in. It is a very wise investment in my opinion.
And it works two ways. One, they can see what you see. The other is you can see what they're not seeing until they do see it.
Okay, great.
Okay.
Thank you.
Excellent. Your brain is not.
John, look like he wants.
Everybody return the glasses, without smudges. If we see a smudge on the one you return, well,
Well, but.
I think the next session is actually very interesting because we combined a fundamental lecture with a very practical lecture, and I think that's going to be very useful for everyone. So a couple of housekeeping items before we move forward. By now, you probably all have found the restrooms. Okay, if we have the Super Bowl effect, there's restrooms directly above and below the ones that are right out here. Okay, those of you that are former people that may have been here, there is a restroom in the cafeteria, but it's locked. So the only ones available to us are the ones right outside the breezeway. Remember, your microphones that are in the lower bowl seats are active. So you can push that microphone down and talk, and it will be microphonized, it'll be louder, and it will be recorded as well.
Right here?
Yes. Yes.
You have to speak a little
That shuts it
louder.
off. So you don't have to pass the microphone around. Wi-Fi, Kane's Guest should be available to you if you need it. Another important issue, please stay after the end of the second talk and discussion. We're going to try to get a group photo right up here in the front. It's always a little bit like herding cats. Let's try to make it as efficient because that's what's between that and lunch. So everybody come on down. We'll get a photograph. I hope you enjoyed the last presentations. I found them informative and enjoyable. And, for most of the people here have done lectures and educate, what work goes into giving a talk and what kind of personal investment goes into that. So I thank our speakers and I thank you for being here. Please engage, right? This talk is for you as well. So let's have the discussion that you feel appropriate. Raise your hand or we'll include you and make it for a more dynamic meeting. Again, thanks to our sponsors. Please acknowledge them and the educational grants that make these meetings possible. Special thanks to Kelly Rogers from the OGS. If you haven't thanked her, please do. Also, I'd like to acknowledge the Bascom Palmer group behind the scenes, Karen Davila, who gave me some really important information to help put this together. Our environmental services team, those guys were here last night cleaning the floor, so this looked nice and make sure that this was a reflective of the respect for this meeting. So I'm grateful for that, our security services, and especially for Alex Rodriguez, who's behind the scenes up in the booth. But without him, this doesn't really go forward as well. So thank you, Alex. So I guess I'm here at Bascom Palmer. Bascom Palmer is a unique place. One of the things that I think makes it unique is the generosity of the people that work here, the free sharing of knowledge. And I think you can all agree that when you interact well, you're receptive to questions and you're generous and kind with each other, people are going to approach you more and communication improves and knowledge advances. So I encourage you to maybe take that back as well. And you never know what impression you're going to have on one of your students. I think that covers the things I was going to say. I don't really want to introduce Dr. Anderson again because we're going to have another video talk for him. But I had to say a couple words, personal stuff. I am not going to contribute to his highly productive career that frankly isn't going to be captured by a CV. It can't be captured by a CV. I'll speak a little bit about my good fortune of interacting with him over the years, and it's a lot of years now, clinically, professionally, personally, yeah, I think this is very appropriate. I've learned a lot from him on many levels. So I want to thank him for his friendship over the years. And I will say that everything that's been accomplished by him, every instance that I've ever seen has been done with kindness, and he's never been less than a perfect gentleman. So I thank you for your example, and I will let the video start next.
Yes, I guess we will now begin to discuss the nature of glaucoma. Let's see here. So I was assigned a rather long title of Natural History and Pathological Processes of the Glaucoma. But in the short, it's what is glaucoma? Our word for glaucoma comes from the Greek word glaukos, which means simply a hazy light blue or sea green hue, something that nowadays would be attributed to a cataract or corneal edema, or actually would be applied to a person from Scandinavia who had blue eyes genetically. The Greek word glaukos evolved to glaucoma, and glaucoma appeared in the English dictionary in about the mid-17th century. And at that time, it was just either cloudiness or a haziness inside the pupil, or maybe the cornea, or maybe just the pupil. And we would now recognize these as corneal edema and cataract. Couching was a process by which you would insert a needle into the eye through the pars plana and engage the lens and rotate it down to the inferior equator and get it out of the way. The best surgeons were the ones who could do it the quickest in less than a second because it was very painful. Glaucoma was then a haziness that was not corrected by couching, or vision was not restored. Amaurosis was the term used for any disease that darkened the vision, and there was no apparent cause on the exterior of the eye with available light sources, which might be a candle or an oil lamp, could be light coming in through the window, or most likely light from a fire in the fireplace or the hearth, which illuminated all of the room during day and evening so that you could see what was going on. Amaurosis thus included anything that was in the inside of the eye, like retinal detachment, macular degeneration, and so on, and including chronic glaucoma. Now, it was noticed that those that had chronic glaucoma seemed to have a firmness or maybe a rock hard eye and experience pain and redness. So the characteristics included that plus the haze that was called glaukos. And it was thought that the problem could be caused by bad humors coming from the iris. And so if you removed the iris by an iridectomy, it might benefit the situation. So an iridectomy was often done, the larger the better. Now, after the iridectomy, some eyes were softer, most were, and they could have, you could have opened a closed angle in them with our modern understanding of this disease, or there could be some drainage from an unintended fistula, and some of them improve vision, which implies that some didn't. How can you see into the eye to see what's going on? Murray immersed a cat in water. Well, I didn't know. Okay. Purkinje noticed the fundus of some animals accidentally on occasion. In 1847, however, was when a mathematician figured out a way that you could be able to see inside the fundus and recognize what the problem was. But it was 3 years later before Helmholtz, quite independently, not knowing Babbage's work, developed the ophthalmoscope. Now, the problem is that the pupils are black. What does that mean? That means that the illumination in the room was illuminating some part of the retina other than the part of the retina that you see by looking directly into the eye. That part of the eye was not illuminated and was in the shadow of the observer, so to speak, and therefore you couldn't see anything but black in the pupil. The problem was solved by Helmholtz by using a candle and having a mirror that shined the light into the eye through a lens, and it's an indirect ophthalmoscopy. And there was a hole in the mirror so that you could see it's in the same axis as the beam of light that was illuminating the inside of the eye. There's a diagram of the candle going to the mirror, into the eye, and then being visualized by the person through a hole in the mirror. Now, let me go off on a tangent for a moment. The ophthalmoscope was actually the most important event of all time for understanding eye disease. Before this, you just had to call everything amaurosis if you didn't see any cause. Helmholtz recognized the importance of his invention in that you could now see inside the eye and see what was going on in patients that you couldn't understand before, why they didn't see. He did, however, refuse to patent his invention, despite the urging of his friends and colleagues, because he thought that it was so important that everybody should know how to do it and they could build their own ophthalmoscope and sell them. He was satisfied to make ophthalmoscopes and sell them to the local people, but he didn't want to patent it and prevent other people from doing so as well. Over the next 50 years, there were at least 350 modifications to the ophthalmoscope described, and they were shown at a meeting held celebrating the 50th year after the invention. One of the additions was to illuminate things by electricity, which had come along meanwhile, about 1900 or so. And it was powered by a wet cell battery, like the battery in a car, and then wires that went up, and you could see that it, here's the wire coming up to the ophthalmoscope that's now being used to illuminate things. And this one was apparently a direct ophthalmoscope. The idea of putting a dry cell in the handle of the ophthalmoscope was brought up by Crompton, and it was commercialized immediately thereafter by Welsh and Allen, which became a well-known company for making instruments, including the first handheld direct illuminating ophthalmoscope. Now, the impact was that there was a demolition of the puzzle of what on earth was going on with amaurosis. There were guesses and speculations, theories and discussions, and of course it was discovered there were many different causes of amaurosis. Okay, returning back to the subject about the nature of glaucoma, with the ophthalmoscope, it seemed that there was no particular change in the fundus. The retina looked just fine. That view was replaced by the belief that there was swelling of the disc that some people thought they saw, but they actually had it backwards. Von Graefe demonstrated that it was actually an excavation of the disc that was seen in glaucoma and not a swelling. And he also observed retinal pulsation. So now for glaucoma, we had vision loss, high pressure, very high in some cases, and excavation of the disc. And these characterized what was known as glaucoma. How did they fit together? What's the central feature? Well, the pressure. The pressure is what caught everybody's attention. They were hard as a rock. And in the 1880s, by the mid 1880s, palpation with different degrees of firmness of the eye and 9 degrees were described. And so evidently there was varying pressure between eyes, some of which were high. And it was determined that there should be some way developed to measure the pressure. And that was finally done at about 1900 with instruments. Schiot's was a popular one, not the first, but the popular one invented in 1905. It required calibration to eyes with known pressure. And that was done in 1948. It's thought to be a bit inaccurate, so it was done again in 1955. Turned out the 1948 one was probably better anyway. But applanation tonometry, meanwhile, came along, and that became the standard. All of them just estimate the pressure. None of them really measure the pressure. Glaucoma is then defined by having a high pressure, and then by what caused it. There were 3 types of glaucoma described where the cause was unknown. In one of them, the angle was open, but there was nothing apparently wrong with the eye. And so the pressure was primary. It was idiopathic. It was the thing that just arose on its own, and there was nothing earlier in the pathogenic pathway that was understood or known. There were some eyes that had angle closure, and that could be recognized as being the cause for impeding outflow of aqueous humor and hence having a high pressure. And then the other one that didn't seem to have a cause other than some congenital anomaly, presumably. Anyway, if the child was born with a high pressure, that was congenital glaucoma, though you couldn't determine why they had the high pressure. Then there were many secondary glaucomas, things where you knew what caused the pressure, things like pigmentary dispersion, pseudoexfoliation, trauma, and angle recession, ice syndrome, and so on and so forth. And there were several dozen of them, and they were tabulated and described in the textbook that was used after 1950 or so, and written by Becker and Schaefer. And they cataloged and characterized and gave the treatments that were available for each of these different kinds of secondary glaucomas. Now, the pressure is the source of the problem, it seemed, because if you had secondary glaucomas that caused an elevated pressure that hadn't been present before, and that caused cupping and vision loss. And you could raise intraocular pressure in animals, and that resulted in cupping. And so it seemed that the pressure was the central issue. So when I was young, it was all about the intraocular pressure. The type of glaucoma was defined by what caused the pressure, and the treatment goal was to bring the pressure into the normal range. It was simple as that. So to diagram that, this is the frequency distribution of the intraocular pressure in the population, and anything that was higher than the mean plus 2 standard deviations, which was 21 millimeters of mercury. Anything above that was harmful. And either you already had some vision loss or it was inevitable that it would happen. On the other hand, anything below 21 was perfectly normal and seemingly safe. So that if you had that, you had no worries. Well, things have changed. And now we view glaucoma this way, that there's a skewed frequency of elevated pressure, let's say, and elevated pressure would be above 21, all of these people here. Now, visual field loss was something different. Here is the frequency distribution in brown for visual field loss. And in the normal range, there weren't very many people. The ones below 15 aren't really real because that's just the width of the pen of the person who drew the diagram. But you started to see some people before you reached 21 that had glaucoma as field loss. That was sort of a puzzle if pressure was supposed to be the cause. And even with a very high pressure, the mean pressure of people with glaucoma was about 23, not really very far out of the majority normal. And even going up to pressure in the 30s or above, there were some people who didn't have any loss of vision, only some fraction of the people with elevated pressure. And let's take somebody at 24. There were more people that didn't have field loss than there were people that did have field loss. I wonder what that was all about. Well, Armley actually measured according to age what the incident or the prevalence was of visual field loss from glaucoma, and there it was. And here is the prevalence of pressures above 20 millimeters of mercury, that is 21 or higher. And they greatly outnumbered the number of people who had abnormal intraocular pressure. And that was a puzzle. This was confirmed in other studies here. For instance, is the black jagged lines is a distribution of people with different pressures at 1 millimeter mercury intervals. The dotted line is a Gaussian curve just superimposed and shows that it was more or less a Gaussian curve, except that the population had a skewed pressure in the upper ranges. Now, down here in the shaded bars are the people who had vision loss. Some of them actually were in what you'd consider to be the normal range. Others were in the range of pressure that would be considered elevated above 21 and so forth. But there were a few outliers really in the high pressure range that had no visual field loss, and hence they're not shaded. And so that was true of all these people between the Gaussian curve and here as well. They had no visual loss despite the fact that their pressure was high. So how do we explain this deviation of reality from what would be expected? Well, ocular hypertension. Maybe it just takes time, but it was felt cupping and visual field loss was inevitable if your pressure was in the elevated pressure range. And therefore, that is because high pressure is harmful and you must treat them. Another rationalization on the other end is that people who had normal pressure must have had some pressure in the past, or they had a variation in pressure, and while they were sleeping or some time of the day or after they drank a lot of water or coffee, the pressure went up, but at other times it was in the normal range, but at least it had some time in the, or maybe they used corticosteroid eye drops when they used contact lenses. And during that time, the pressure was high, but in their older age, they stopped wearing contact lenses, stopped taking the steroids, his pressure came back to the normal range. And now as you see them, they have cupping of the disc that is typical of glaucoma and visual loss, but the pressure is normal. But it wasn't normal before. That was the rationalization. They need to be treated, or they didn't need to be treated, however, even though they had cupping and field loss, because now they have a normal pressure, and that's not harmful. You see, glaucoma is all about being high, stupid. So there. Well, since over the subsequent 60 years, there's been considerable change. Armley began to question whether high intraocular pressure indeed defines glaucoma. He began to explore the natural history of what we now call ocular hypertension. Bo Bengtsson and other people in Sweden actually thought that the intraocular pressure and the cupping and field loss were two separate things. Some people, and they get older, they got cupping and field loss. And some people had higher pressure in their eyes than the younger people. But neither one caused the other. The pressure didn't cause the cupping and field loss. And because of that, there was no need necessarily to treat the intraocular pressure and make it normal because it was not doing anything. Just a few years later, in the 1980s, Eddie, who was a pioneer in evidence-based medicine, pointed out there were many conditions in medicine for which there was not much evidence of what was causing it, and not much evidence that whatever treatment was being used by tradition and as taught by the professors whom you believed without asking for evidence. He challenged that and said there wasn't any actual evidence in the literature, and he chose as one of his examples ocular hypertension. So there's no evidence for that being treated, no evidence that glaucoma needed to be treated or that any benefit arose. Oh, and everyone was so disturbed by that concept. Of course, the intraocular pressure is harmful. We all know that. And that's what's causing the problem, and you got to treat it. It would be unethical not to treat it. And Eddie said, where is your evidence? And annoyed everybody. It turns out, however, maybe he was right. There wasn't any actual evidence that doing anything about the pressure brought any benefit. And now we know what we know. Now, how should we think about the intraocular pressure now? We use it for screening in the community, and that turned out not to be a very productive adventure. Didn't uncover many cases, and a lot of cases went undetected, and began to realize that the two were disconnected. But we still, in the office, check the intraocular pressure and say we're doing a glaucoma test, as if that would detect glaucoma. And if you remember the graphs that we had, that would only detect maybe half of the people with glaucoma, and most of the people who screened positive with an elevated pressure actually didn't have glaucoma. So it's not very effective. Of course, we take the opportunity when the person's in the office, we do that. It is one of the risk factors that we now know to be true, that it can lead to or be a sign of an existing glaucoma. And so we continue to do that in the office. Every single visit is just part of a routine exam. Do we need to do it every visit? Probably not. Probably if we're, checking the pressure once a year or something like that, once every few years. That's enough, but we still check it every single visit on that comes in for dry eyes or anything else. Nowadays, however, we don't really believe that the pressure is the real key. With reference to management, we understand that glaucoma is identified by other things besides the pressure. And once we have done that, we look at what the pressure is and we set a target pressure, something that Paul Pumbert has strongly advocated, in order to get it to a safe level. So instead of separating normal and abnormal, we now want to separate safe and unsafe. And the evidence for being unsafe is that you already have some cupping and field loss. And if the pressure is 23, let's say, and you lower it to 17, maybe that's quite enough. You got it into a safe range for that particular person's eye. If somebody has a pressure of 35, maybe they're, and the cupping isn't really total or anything, maybe just getting it down into the low 20s somewhere, 23 or 24, maybe that's good enough. And so we might undertake management that brings it to a safe level in that eye. And until something comes along to change our minds, we might consider 23 to be good enough. We don't have to go to a dangerous level of treatment or one with a lot of side effects unnecessarily. But we're not simply trying to get it to the normal level. The other way that we use intraocular pressure is to look for effectiveness of treatment. So before and after you start a treatment. And once you get what seems to be a substantial lowering of pressure, and you have reached your target, you measure the pressure on every visit. Now it seems worthwhile. They actually have a disease related to pressure, and it's worthwhile measuring it every time to see whether or not you're at your target, but not to see whether it's a normal pressure. So intraocular pressure is a risk factor: age, family history, vascular dysregulation, cardiovascular state. We're going to get into all that. They're all risk factors. Then the disc tells you whether or not there seems to be something wrong. And in any suspicion, you get a visual field test. That's how we detect glaucoma currently in the office. So what are the mechanisms behind this? First of all, the mechanism for the elevated intraocular pressure, and secondly, the mechanism for damage to the disc. With regard to the pressure, the resistance seems to be in the outer trabecular meshwork and was shown, in the 1960s and studies around that time by people who worked in the laboratory and were able to kind of shave off parts of the trabecular meshwork and determine that increased the outflow of aqueous humor. To a lesser degree, there's some resistance in Schlemm's canal and the collector channels. And then there's the episcleral venous pressure. And all of this leads to Goldmann's formula, which you should know, which relates the intraocular pressure to the resistance and the venous pressure, as well as the rate of flow of aqueous humor. Those are the three things that determine pressure. Sonography was used to measure the resistance. It was one way to be able to do it in a living person. And when it was used clinically, however, it was found not to be more informative than measuring the pressure itself. And so while it was used clinically for 5, maybe 10 years, rather routinely, it was discarded after that. There are laboratory studies or biochemical studies, let's say, about the trabecular meshwork and to understand what's going on there in order to have the resistance. And I don't know too much about those things. There is one medication which is involved generally in cell contraction, rho kinase inhibitor. Rho kinase is responsible for contraction. The inhibitor inhibits that, and it does lower the intraocular pressure. I don't know whether more often or much lower than with other medications, but it's something that's there, and I don't know much more about that. And so we'll move on to something that I do know more about, and that is the optic nerve end of the equation here. The intraocular pressure will induce a blockage of axonal transport. It's the first physiologic process that was discovered to be upset by raising the intraocular pressure. So what are we seeing here? This is an eye where a radioactive amino acid, probably leucine, for example, was injected into the vitreous. It was taken up by the Golgi apparatus in the retinal ganglion cells. And the protein that was created there was carried along the axons through the optic disc and all the way to the lateral geniculate body. What we see here is that the radioactive material was being carried along, but got hung up in the region of the lamina cribrosa, or at least where it goes through the choroidal layer. And it doesn't get to the lateral geniculate body. The whole process takes 4 hours to get there, but here after a few hours, you can see that it doesn't get there at all because it's hung up here when the intraocular pressure is elevated. And the degree of blockage is related to the degree of elevation of intraocular pressure and everything else. Now, the problem is that blockage of axonal transport is a lethal injury to the axons and their ganglion cells, because there are also messages being carried in the opposite direction by the same active transport process that's carrying some proteins in the orthograde direction. And if the ganglion cell is not receiving messages from the receptor, it decides it's become disconnected and it undergoes a process of apoptosis. And the ganglion cell dies. Apoptosis is a process where the nucleus creates some enzymes and things that simply dissolve the cytoplasm of the cell, and it liquefies, and it's just absorbed into the body fluids, and so on. It's the opposite of a cell dying by necrosis. In necrosis, the cells are deprived of blood flow and nutrients, and the cell just dies. It doesn't get dissolved. And so macrophages and inflammatory cells have to come in and sort of clean up the mess behind the dead cells. That causes a retinal inflammation around the dead cells to clean it up. Very different process. This process is a self-imposed death when it's disconnected from its target organ. So now we can talk about methods by which the intraocular pressure blocks axonal transport. Been some debate about this in the past, at least. There might be some mechanical thing. The axons are kinked where they're leaving the eye through the lamina cribrosa as they go through the sclera. Or there's a pressure gradient along the axon, or some mechanical reason for the blockage. The contrary viewpoint, or an alternate viewpoint, is that there's some ischemia that's localized in the region of the deep optic nerve head because the transport is oxidation dependent on ATP, oxidation process, and ATP is not formed if there's no oxygen around. And the vascular consequence of intraocular pressure is that there is no active energy in the form of ATP to conduct the transport. I happen to believe that's the main mechanism. Not everybody is fully convinced, I guess, now. But here we come back to our diagram, and this blockage, I indicated that the degree of blockage was dependent on how high the intraocular pressure is, but it turns out that if you give a vasoconstrictor of angiotensin it makes it worse. Now, angiotensin can't enter nervous tissue, the brain or anything else because of the blood-brain barrier. So it doesn't enter into the retina or anywhere along the optic nerve or inside the brain, except where there's a defect in the blood-brain barrier. And that is at the choroid. The choroid has no, it doesn't have a blood-brain barrier or blood tissue barrier. And the angiotensin can seep out into the optic nerve head and cause vasoconstriction locally in this particular region. And so even though angiotensin raises the blood pressure at the same time, it should make it easier for blood to flow through the area, there is a worsening of this blockage by angiotensin. Other evidence that blood flow is involved is that there's a relationship to the diastolic blood pressure clinically. And there are hemodynamic crises that can cause an acute kind of cupping. And nocturnal dips in blood pressure occur in some people, and those people sometimes have glaucoma. And so other vascular events seem to affect it. There are lots of studies about the relation of what's called ocular perfusion pressure. That would be the blood pressure minus the venous pressure. That's what pushes blood through the capillary bed. It's intraocular pressure is substituted here because one of the things that intraocular pressure does is to raise the venous pressure. And it's above that the venous pressure would be in the orbit. And so the circuit that's in the optic nerve head or in the eye in general, in the retina, is the blood pressure minus the venous pressure of the eye, which has to be at least as high as the intraocular pressure. Another evidence for blood flow involvement is that migraine and vasospasm and vascular dysregulation and other vascular problems are related, and we'll see some things about that. There is an uncertain relationship with arteriosclerosis. Now that's in the larger vessels of the eye. And these two, the microcirculation, which is affected by vascular dysregulation, and macro circulation, the arteries, are affected by arteriosclerosis, atherosclerosis, and so on. And so all of this suggests that that the vascular system is somehow involved in this problem. Now, a separate topic is that cells undergoing apoptosis can be made to be fluorescent. And these fluorescent cells can be seen in retinal images and be counted. And the number of fluorescent cells reflects the rate of progression and guides there. In other words, the more cells there are that are undergoing apoptosis, the more progression that's occurring at the moment. A clinical method to do this is under development. It might be 10 years or so before you see it, but it's coming, and it's based on the fact that there is apoptosis caused by axonal transport seemingly. Now, the other aspect of this that's of interest is that the blood flow in the capillary bed is auto-regulated in CNS tissues, central nervous system, CNS. And that includes the retina and the optic nerve and everywhere else. So a study was done on the optic nerve head of 10 normal subjects of the blood flow in the capillaries of the optic disc. Wasn't an easy study to do, so there were only 10 subjects. In 8 subjects in the left here, the blood flow remained the same in the capillary bed until you got up to about 50 millimeters of mercury, which happens to be near the diastolic blood pressure of the patient, or not patient as a normal subject. And this black bar represents the blood pressure. And then when you get higher, why then finally the blood flow declines. When you release it, as in the open circles, the blood flow is restored as the intraocular pressure is brought back down in steps. There was a little bit of an overshoot because of hyperemia right there. And finally it comes back to the baseline. In two subjects, it was quite different. The blood flow diminished as you raised the intraocular pressure. And then when you released it, the blood flow came back. So these people didn't have any regulation of the flow. The flow was diminished. Now, one of the interesting things about this, that in the ocular hypertension treatment study, the number of people who were found to have ocular hypertension and were followed without treatment, who nothing happened to, was about 80%. Only about 20% of the people over a period of several years developed glaucoma. That's interesting. It means that some people may have elevated intraocular pressure, nothing's happening to their blood flow, and in the long term, nothing happens to them. Might bring up the treatment question of whether they need treatment. So the hypothetical elements of ischemia is that there may be a deficiency of metabolic autoregulation in some people, and therefore ischemic damage. In addition to there being intermittently, at least perhaps, a change in the blood flow, there may be, when there's a restoration of blood flow, there is a reperfusion injury. That's a well-known physiologic phenomenon, that if you make an area ischemic, it's okay for it to be ischemic for a certain length of time, and then it can be released. It's why you can have your blood pressure taken and cut off all the blood flow to the rest of your arm, and then why nothing happens in particular, because there's reperfusion promptly. But if the reperfusion is a little bit prolonged, why there can be an injury caused by reactive radical ions, and there can be an injury to some of the tissue because of that. And that could be occurring if there's intraocular pressure elevation that exceeds the ability to auto-regulate, and it lasts for a couple, 3 hours, and then you release it. The axons might be saved, but there might be some injury. Hypothetical. There is a variation in ocular hypertension sensitivity. And for example, you have normal tension glaucoma, but there normal tension glaucoma study we'll get to show that if you lower the intraocular pressure, it helps some of the people anyway. And so although the pressure participates, there's a lot of individual variation about how harmful it is. That's the message from here. Blood flow should be lowered when there's an arteriovenous pressure difference that's reduced, but autoregulation maintains the blood flow, at least in some people and at least some of the time. What are the clinical signs of dysregulation? We can recognize people who have a problem with the regulation. Remember, there were the two normal subjects that didn't regulate very well. They tend to be nervous people that have cold hands, cold feet. They wear socks when they're sleeping. Their hands and feet get cold when they're nervous, like when they have to give a talk. Oftentimes they had a low blood pressure when they were young, so there was only 100/60 instead of the normal 120/80. They oftentimes don't have a real sense of thirst. Yeah, they drink water because they need to wash the food down and they know they should drink water, but they don't have a sensation of thirst when they don't have water for a while, like people have a sensation of hunger. Other people do have a sensation of thirst when they have gone a while without drinking something. Migraine headache takes them a long time to fall asleep. Instead of 5 or 10 minutes, it might be half an hour or an hour. Tinnitus, I haven't actually seen that, but it's described. Now, there has been discovered some evidence for 2 different kinds of glaucomatous damage when people consider the amount of damage and the level of intraocular pressure. They're brought into clusters. There's a very interesting paper on this that we don't have time to go into, but basically what it shows is that some people have damage, the severity of the damage in their eye is unrelated to the level of their intraocular pressure. Whereas people who have the dysregulation that we just described in the microcirculation, as opposed to the major arteries, their damage is related to the intraocular pressure level. Well, do you have any questions? Yes, I guess we now begin to discuss the nature of glaucoma. Let's see here. So I was assigned a rather.
All right, well, thank you very much. We've got a few minutes for questions before the next presentation, I think. And I welcome any from the audience. I guess one of the questions, what's the point you ended on? How does a clinician try to determine what's the major vessels and what might be the minor vessels? The more.
Is this microphone working?
Yes.
Yes, okay, good. Well, I won't take up too much time because the next speaker is going to be a very high interest and we run overtime a little bit here. But I think the main points here are that intraocular pressure is certainly involved in things, probably interacting in some way with the vascular system. And different people have different susceptibility to different levels of intraocular pressure. And we saw some of the pathophysiology behind that. The big question is whether we can now work on identifying these two different types of vascular problems, because one seems to be pressure dependent and the other one seems not to be. And if that's true, the ones that intraocular pressure is not involved in the pathogenesis, then it's kind of dumb to try to lower the pressure because it does no good. So we will hope that somehow science will catch up and teach us how to recognize these two different types. But right now, we can recognize the vascular dysregulation by some clinical tests, but also the symptoms that we talked about. And the other one is people who have either themselves or in their family heart attacks, strokes, and other things that represent atherosclerosis. And those are not pressure sensitive and they may not need treatment. We just have to wait to see.
Okay. And I guess
I don't know what
the import is there another alternative, is there another therapeutic modality down the road that those patients might benefit?
On the other hand, since it's been shown that at least 90 to 95% of people with glaucoma can be stopped from progressing if the pressure is low enough, it's probably worth treating anybody with glaucoma. And I would say it was interesting in SIGITs, and I'll show the data later. People that had a heart attack or stroke were stabilized by getting their pressure down, but they didn't improve. And the ones, women were more likely by 60% to improve when their pressure was brought, actually have a 3 decibel improvement in their visual field in SIGITs when their pressure was lowered. And the best vasoregulation problems probably relate to that. And in normal tension glaucoma, you found those were the people most likely to get better. Now, I guess is what you're saying, some people with normal tension glaucoma, there may be vascular problems so that lowering the pressure doesn't matter. I think people with high pressures, we've really been able to show that just about everybody can be benefited by getting the pressure down.
Certainly the standard of care at the moment is to lower the intraocular pressure in people that have glaucoma. So we wouldn't want to deviate from that except in an experimental setting, which would require, approval from the ethics committee and informed consent and all the rest for people who are not going to be treated that otherwise would be in the standard practice. So we await that day to find out whether Paul's perception is correct or not, that all people benefit from lowering the intraocular pressure, or whether there's a subset that benefits and dominates the mean effect. So I guess we keep our eyes open for that.
I would say nearly all. I wasn't saying all.
Yeah.
Well, and I think we can recognize that the mechanisms are not mutually exclusive either. There may be a good deal of overlap and contribute.
And I bring up the two different types here simply that we're aware of the fact that there is some evidence for two different types, and we need to wait for more evidence of the details.
and techniques easier to do implement than the ones you had to use, right?
Yeah.
Laser Doppler flowmetry was no walk in the park.
Laser Doppler flowmetry is not good.
Well, in the interest of time, unless there's a burning question that no one's going to be able to sleep if they don't ask right now. Okay, we'll move ahead then to the next speaker, which I think everybody's happy to. And I guess it doesn't really need an introduction in glaucoma to circles, but I will try to make a brief intro right now as a leader in the very well-recognized voice in the glaucoma world. Background of Harvard Medical School, Barnes Jewish Hospital for residency and fellowship. She's a long-standing faculty member of Bascom Palmer Eye Institute, specializing in pediatric and adult glaucoma. She has a unique perspective of having been in academic medicine for years, as well as being in private practice for a period as well. I think that brings a very practical and important perspective for all of us. Dr. Hodap enjoys a well-earned reputation as a clinician, as an educator, as a mentor, as an author of the Clinical Decisions in Glaucoma textbook. There's 2 versions that have been done, or largely, I think the authors would agree, they're driven by her. And without her input, it really never would have got forward. I think that her contributions from my experience, and I value my interaction with her on a regular basis, universally intelligent and insightful and very practically applicable. And that just reflects her knowledge, her experience, and a really caring nature. So I think she has a lot to offer, and I hope you'll welcome and give your attention to Dr. Hodap.
Don't leave until I make sure I know how this works. Okay, thank you very much for that very nice introduction.
So, Dr. Hodop, if it doesn't advance, just click one time.
Click the mouse.
Yep, just click one time with the mouse on your slide, and then you can forward with the keyboard.
Oh, on the slide. Okay, excellent. So thanks for inviting me. I have no disclosures. I will be regularly referring to the Clinical Decisions in Glaucoma. I call it either the book or CDIG. The second edition, there's a little picture here. This is currently available on the American Academy of Ophthalmology website. And we are also, and I've mentioned this to a couple of people, we would be very happy to make it available to your website or to the Optometric Academy website for free if you are interested. We're just interested in improving the care of glaucoma, okay? Not particularly interested in royalties, and they're really small anyhow. And they don't go, the second edition doesn't go to me, it goes to Peter Chang. So I should go back, but will double click make me go back? Well, let's just pretend I went back. Mike Patella referred to that book as a textbook, and it is definitely not a textbook. It is a management manual, okay? And it's the target audience for the first edition, the person I had in my brain was myself as a resident when I just didn't know what to do. And I knew it mattered, but I didn't know what to do. And the goal was to help people steer between grievously undertreating people and grievously overtreating, because you don't want to do either one. So we made specific recommendations, not a lot of footnotes, arbitrary, it wasn't capricious, but it is not a textbook. Anyhow, we start out with some precepts, okay? And you know these, but let's go over them. The higher the pressure, the greater chance you're going to get glaucoma, and the faster you're going to get worse. Pressure isn't the only risk factor for developing glaucoma, but it's the only one we can treat. In people with glaucoma, lowering the pressure helps, but you're not going to know prospectively how low you have to go. All ways of lowering pressure have costs, risks, and side effects. And the goal of treatment is to keep the patient seeing for their lifetime as inoffensively as possible. And these are the kinds of things that I think, what I'm going to talk about today is what I think are the basic things to teach your trainees. So we come up with kind of two basic statements, okay? And that is that glaucoma management involves balancing the risks and benefits of lowering the pressure in each patient individually, but we lump them into categories so we can get something written. And glaucoma management depends on the ability to recognize change over time. Can't emphasize that one enough. So these are our steps. You treat treatable things. If someone is in ankylosing, you treat it. If somebody has inflammatory disease, you treat the inflammation. You treat the treatable things. You establish a baseline. You decide if you need to treat, and if so, you set some kind of a target. You try to get to that target. If it's hard to get there, well, you decide, how hard you have to go. Maybe you reevaluate. Then you follow the patient to see, is the pressure controlled? Is there evidence that the patient's getting worse? And you modify based on the patient's course. So let's start out with establishing a baseline. You've already treated the treatable. So here's a patient who comes in 2020, emetropic, pressures of 24, normal corneal thickness, open angles, normal anterior and posterior exam. And these are the nerves. They're normal. We'll call them 0.3. And yes, I will use numbers. They are used in the book. I understand the problems with numbers, but this is 0.3 cup. So what's a baseline? Fortunately, several people have talked about this. What we recommend is a minimum of 3 applanation pressure readings, ideally at different times of the day. A gonioscopy, pachymetry, 2 visual fields. If they're very different, a third. RNFL, ganglion cell, OCT with a minimum signal strength of 7. And optic nerve photographs. Thank you, the people who came before me. I don't have to explain why we want optic nerve photographs. And this is something that you're going to want to get in over the first several months. And obviously, you're getting multiple readings. It means multiple visits. So this patient has a pressure of average of 23, normal fields, PSD of 1.5, normal OCT. The RNFL is right in the middle of the green. It's a normal contour, normal ganglion cell. The photos are clear. What are you going to do? Now you have to decide if the patient needs to be treated, and if they need to be treated, you set a target. Well, actually, we have 3 patients because the same findings here, I have 3 people, and we've got a 40-year-old with a strong family history of glaucoma, a 60-year-old with diabetes and hypertension, but without retinopathy, and a very healthy 80-year-old. And I asked this question, whoops, let's go. Try it again. I'm not very good at this. I asked some question here. Do you treat to lower the pressure? If you're going to treat, how? Medicine, laser, incisional surgery, what's going to be your target, and how often do you follow the patient? I, at a meeting a few years back, asked 8 recognized glaucoma experts this question with these pictures. And these are the results. As you can see, the most likely to be treated was the 40-year-old because of the strong family history. And that was 2 of the 8 would treat, 2 maybe. Just 1 person recommended treatment of the 60-year-old or the 80-year-old. Everybody was talking drops. Okay, we were not lasering and we were not doing incisional surgery. You can see the goals there of the 2 people who would definitely treat. And then the frequency of visits were pretty much the same across the board. Either 2 visits a year by 1 patient, 1 to 2 by 1 doctor, 1 to 2 by 2 of the experts. The other 5 thought yearly. And once again, this was the same across the board. And they recommended, once again, after a baseline, okay, we've already established a baseline, yearly testing. So let's go to another patient here. This is a patient who came into clinic at Bascom Palmer for glasses in 2016, 65-year-old, type 2 diabetes and hypertension, 2020 mild refractive error, pressures of 22 and 23, thin corneas, normal anterior and posterior segment. These are his nerves. I think the left one looks a little vertical. This is his field. It's not frankly abnormal. It's not completely perfectly normal. This is his OCT, which isn't normal. So how do you diagnose glaucoma? left this one out. Minimally elevated pressure, thin corneas, cupping, full rims, borderline field, abnormal OCT. In CDIG, we have set up minimal criteria for diagnosing glaucoma on an initial exam. So we're talking about an initial exam. On initial exam, we expect to have elevated pressure and structural damage and functional damage. Now, on subsequent exams, you can have a person who has structural and functional damage, but normal pressures can show up and have a high pressure, at which point we would make a diagnosis of glaucoma. You can have a change in the visual field or the OCT, but for an initial exam, we have required all three. And this is because you have to write something in a book, and I think it's perfectly reasonable and we'll stand by it. And our patient would not quite have met that, although very, very suspicious because he didn't have absolutely frank visual field. Fortunately, of course, he had records, or not of course, but fortunately he did. And he had been seen in 2009 with elevated pressures in a much more abnormal range, had photos taken then. There was a mention of getting an OCT, but he didn't get one. He got a field in 2009. He was supposed to come back for another one. When he came back, he didn't get his field. In 2012, he came back. He had a field. He had an RNFL exam performed. It was reported as full, but the printout was lost, so I can't show it to you. I can show you his fields from 2009 to 2016. And I don't think we could knock down progression based on his fields. His right optic nerve hadn't changed. However, his left optic nerve had. He had had some thinning both superiorly and inferiorly. And in conjunction with the OCT, which I showed you previously, we were able to make a diagnosis of primary open-angle glaucoma. That's just a little example of, we would not have been able to diagnose him absolutely if he had not had those records. We'll get to, I think we probably would have treated him anyhow, and I'll explain why in a minute, because we're going to go back to ocular hypertension. In our book, we divide ocular hypertensives into three categories of suspects: high, medium, and low, not too surprisingly. High risk, pressure over 32. If the cornea is less than 555, a pressure greater than 26, and a vertical cup disc ratio of greater than 0.3. And these numbers, by the way, are based on OATS. Obviously, all of your OATS data came before, or all of your OATS baselines came before the time of OCT. So whatever you read about risk factors and risk calculators with OATS do not deal with OCT. There are certainly people, I'm sure, who were entered into the OATS study who would not have made it because they would have been diagnosed as having glaucoma. But it's still a great study. It taught us a lot. So anyhow, a high-risk suspect could either have a high pressure, or if the patient has either an abnormal RNFL or a visual field defect. Now, somebody with a visual field defect obviously never would have made it into OATS, okay? Low-risk suspect is somebody who's not a high-risk suspect and has a cornea which is thicker than 588. And then a medium-risk suspect is everybody else, and that's our definition. Low risk suspects, that is pressures less than 32, normal field, normal OCT, cornea greater than 588, we recommend observing unless the patient strongly prefers treatment. Semi-annual follow-up for a year and then yearly. Once again, remember, we've already established a baseline. So you've already got a couple of visual fields. Medium risk, these people have a pressure less than 32. If their cornea is less than 555, they have both a pressure less than 26 and a vertical cup disc ratio less than 0.3. Normal field and OCT, and we recommend that they be observed. Okay. Unless they strongly prefer treatment, or their fields and OCTs are unreliable, or their nerve is hard to examine. Did I write something wrong up there?
What is CD?
I'm sorry, vertical cup disc ratio. CJ, oh, I said that really quick. Clinical decisions in glaucoma. Sorry, I think I said it, maybe I didn't. Okay, sorry. Yes, thanks for asking. No, I thank you. And if treating a medium risk suspect, we'd like to get the pressure at least 15% below their baseline. However, when you are treating glaucoma suspects, if you don't have a diagnosis firmly knocked down, I think it's really important to remember that if the treatment turns out to start being complicated, if there's a lot of side effects, you can stop, okay? You can just pull back and follow the patient. As far as the frequency of follow-up, we would recommend here the same follow-up as for early glaucoma, and we'll get to what that is a little bit later. For our high-risk suspects, high-risk ocular hypertension, pressure greater than 32. If the cornea is less than 555 and they have either an IOP greater than 26 or a vertical cup disc greater than 0.3 and have either OCT or a visual field defect, we call them a high-risk ocular hypertensive. And we recommend that those people be treated unless the patient specifically prefers not to. There are certainly some people who don't want you to do anything to them until you know they've got a disease. If well-tolerated treatment does not achieve lowering, usually stop it. We follow them the same as early glaucoma. And just a personal comment here, if we're treating somebody a high-risk ocular hypertension, I have certainly considered and have been involved with resident service in doing SLT. I think that it can be a perfectly reasonable treatment, depending on the patient. So what about normal tension glaucoma? I obviously haven't said anything about that. And I know Doug has said some things. There's going to be another lecture, so I'm not going to say very much. I currently don't think of it. I don't think it's a separate entity from higher pressure glaucoma, but I find it convenient to pretend that it is. Okay. And by our criteria, which demands elevated pressure, for initial diagnosis, you certainly cannot diagnose normal tension glaucoma on an initial exam. There are initial findings that are very suggestive, and Doug went over some of those: high pressure, typical defect, typical glaucomatous damage, bilateral nerve fiber bundle defects, disc hemorrhage, and migraine, family history, etc. We divide normal tension glaucoma suspects into two groups: the low risks, that is normal or very early field loss, and no abnormal visual field findings within the central 5 degrees. We do these on function, not on structure. And the high risks, moderate or severe field loss, or any abnormality within the central 5 degrees. And these we treat. Don't treat the low risk, do recommend treating the high risk. Once again, obviously, when you are treating suspects, we'll get to what we're going to be aiming for in a bit, but if you're treating and you make no headway with your treatment, you can stop and continue to follow. The next step is to set a target and treat the patient to try to achieve your target. And there's some inconsistent terminology. People use the term target, and we used to talk about goals. Our definition of the target as being the upper limit of the range of pressures that you consider to be safe, which in translation means, since people's pressure varies, that you're going to sort of set a goal of an average pressure somewhat below your target. It's important that you know what you mean by target. But that is the term that we use and that I'm going to be using for the recommendations that I make that talk about target. And when you're going into how to set a target, you want to think about how many recognizable steps of getting worse does a patient have before they lose significant function? How many times can you say, oh, this person is worse? If there's a whole bunch of steps, a whole bunch of times that they can have progression that you can recognize, that's much more comfortable than if you've got somebody who only has a couple of recognizable steps of progression before they are in big trouble. Okay, it's very different. If the next step is wiping something out, it's much, much different than if the next step is, oh, there's a new scotoma up supratemporally off in the mid periphery. Okay. So we have a rule of thumb, of course, for an initial target. For patients who have elevated pre-treatment pressures with early field loss, 25%, moderate to advanced field loss, young patient or fixation threatening, we've set 14, older patient without fixation threat, 17. Normal pre-treatment pressure, that is your normal tension glaucoma suspects. Early field loss, reasonable to observe. Moderate to advanced field loss, aim for a 20% reduction. And of course, all of these things are, you know, a little bit variable. What to do initially? Well, the question of initial treatment is medical versus surgical. Either treatment, either drops or SLT is a perfectly legitimate initial treatment. The light trial in the UK, which I'm sure you're familiar with, favored SLT. I can assure you, I started offering laser as an initial treatment after the glaucoma laser trial came out in the 1990s when it was argon laser. And the vast majority of people, when offered laser or drops, will choose drops. That's just, most people choose drops. I realize that most optometrists cannot personally do an SLT. If you, however, would have an SLT as your initial treatment, then I think that you should offer it and offer to refer an SLT. If that's what you would do, it's definitely something that you should offer. If medical treatment, you're going to start with drops. And ideally, you're going to use something once or no more than twice a day. And usually people start off with a prostaglandin. And so let's just say you do that and you don't get to your target pressure. You'd like to have a lower pressure. What's the next thing? Well, next thing is either drops or laser, whichever one you didn't use first. Okay. And then the sequence would be to go to topical therapy with side effects that are tolerable, non-bleb forming incisional surgery. And by the way, what we put in here obviously is that when I say non-bleb forming, it means that you should refer the patient to somebody who does surgery. Now, referring doesn't necessarily mean that that person is going to do surgery, but I would get a referral before putting a person on carbonic anhydrase inhibitors. Okay. So then systemic carbonic anhydrase inhibitors, once again, depends if it's well tolerated. And then bleb forming incisional surgery. That's the sort of basic sequence. Meds or laser, whatever, then topical therapy that is tolerable, and then consider surgery, then oral agents, then bigger surgery. How do you follow people with glaucoma? Another big question. Now, we're not talking here about baseline. So people have already had a couple of fields. They've already had several pressures. Mild field loss also, as you may recall, this is moderate and high risk ocular hypertensives. Every 6 months for 5 years, then yearly, with OCT and fields twice in the first year, then yearly. Moderate field loss, every 3 months for a year, then every 6 months, fields twice a year for 5 years, then yearly, and an OCT yearly. Severe field loss every 3 months with fields for first 2 years, then every 6 months. Depending on the field, depending on the damage, you may want to alternate the 24-2 and a 10-2, or use a 24-2C to get to get those central points in. And an OCT every 6 to 12 months, if not at floor. Once again, these are arbitrary. They're modifiable, but we think that they're a pretty good place to start. So the basics here is to come up with a rational plan. I strongly recommend that you write your plan down where you can see it and put a date on it. And I strongly recommend that you teach that. You follow your plan if things are going okay. The nice thing about writing it down is you don't have to think it through every time. You think it through carefully, and then if it's like a 3-year plan for the next 3 years, if things look good, you don't have to completely work it all out. Include a reevaluation date or an event. And here's an example from a patient I saw in November of 2019, which was a visit every 6 months, field every visit, alternate, until we had the 24-2C and then reevaluate. So that was it wasn't my reevaluation date, it was my reevaluation event, and then get an OCT about yearly. And that was actually copied out of Epic. So that's what I wrote down. I find it very useful. Yes, Doug.
Yes, I was going to ask you, these recommendations for follow-up, that's assuming that meanwhile, there's no progression observed.
Of course. I'm sorry.
If you observe progression, then you would change.
If you observe progression, we will talk about that soon. But thank you for bringing that up. Thank you very much. I should have said it, but everybody here is smart. They figured it out. Okay. So when do you decide, to advance therapy? Yet, what?
I just said your CPU is faster.
Oh. Well, if the pressure is at a level previously known to cause damage, that is, if you haven't made any headway, then you would advance therapy, which is kind of the same thing as if you didn't get to your target, okay? If your pressure is consistently above your target and it's not very risky to advance, if your next step is not incisional surgery, particularly if you're worried, you're probably going to advance therapy. If you see a disc hemorrhage, even if you haven't noticed a corresponding loss of structure or function, again, if advancement is not a very risky step, you're probably going to take the next step. And certainly, if there's worsening of a measure of structure or function outside the variation of the method, that is, if the patient has progressed, you're going to want to be advancing therapy. Now, how do you decide if they've progressed? If you think the cup has gotten worse, take another photograph, because you already got one at your baseline, and compare photo to photo. That is, I think, much better than comparing on the hoof to photograph. Visual field defects. How do visual fields get worse? Well, you can get a new defect. You can have an enlargement or a deepening of an existing defect. But what you're going to want to use is you're going to want to use the guided progression analysis, okay? You're also going to want to confirm a field change unless there are other indicators. If somebody comes in and their pressure is 42 and their field has gotten worse, you aren't necessarily going to wonder if you need to advance therapy. OCT, you're going to use, once again, use the software. Use the GPA or the Heidelberg Progression Program. We have put down as a greater than 10% decrease in average thickness, or 10%, I mean 10 micron, or 5 micron with the corresponding field change or disc hemorrhage on the RNFL, or a greater than equal to 4 decrease in the ganglion cell. But once again, you really do want to use the software. It's extremely useful. There are pitfalls of looking at fields, just eyeballing fields. And a couple of these, John McSorley, I borrowed some things from him. One is, if you're looking at the black box of the deviation plot, it can't get any darker than completely black, okay? And that's 0.5%. I just drew a little circle around the points on these that are on both these, the total deviation, the pattern deviation. These are the things that are black on both of them. And you'll see in there, there's a couple of points that are at 23 decibels, a couple of points that are at 19 decibels. You can lose a lot of decibels and you're not going to change the color of the box. If you are using the grayscale, similarly, the symbols for the grayscale change every 5 decibels. So you can have a change of between 1 and 9 decibels that causes a change in the symbol. So just eyeballing it isn't ideal. Those problems are not part of the guided progression analysis. And I know you're familiar with this. You've got the baseline fields up at the top. The machine will toss out the first one if it's not appropriate. Then you've got your indices. You've got your visual field index over time. You've got a projection for the next 5 years over here. You've got a rate of change. You've got the current field, and you've got some stuff here that I'm going to show in larger detail. So this is our patient that I presented, the patient who we with glaucoma, and he was diagnosed in 2016. Here he is in 2022. This happens to be in April. He's progressing at 1.6 minus plus or minus 2 per year. Down here, we've got the visual field from April. And this visual field has, as you can see, some things over here, triangles. The triangle symbols are really, really helpful. As you know, the open is 0.5% deterioration on one field. The half is 2 consecutive fields. The full box is 3 consecutive fields. And what you see here is he's got some points that have progressed on 3 consecutive fields. And this is read out as likely progression. Now, a surgical decision was hanging in the balance, so we repeated the field. It came out a little bit better. If you notice the box here, it's up higher here, lower rate of progression, but the program still points out that he is likely getting worse because he still has these clusters of points that have progressed on 3 consecutive visual fields. I don't know if that might have been something you could figure out spending half an hour looking at the fields. The machine does it for you right away. I just want to give a shout out to a wonderful book, Excellent Perimetry, the 5th edition, what started out as the Humphrey primer. And just also to point out that Mike Patella will be happy to send you a PDF of this to share with your students. And Zeiss will be happy to send you, if you ask them nicely, hard copies for your students. Okay, it's a wonderful book, and you should really make that available. There's also a guided progression analysis for the OCT. For the first 4 fields, it shows you just little, there's the first 2 fields, as you know, are the baseline. Then for the 3rd and 4th, points that are either possibly getting worse or likely getting worse. When you get to 5, it starts running regression analyses and giving you similar information. And it runs measurements for this group of average and quadrant and cup disc and so forth. And there's a similar program for the ganglion cell. You can't rely on the green when you're looking at OCT, okay? Because green covers a lot. And if we assume a floor of 50, if you start an average of 89, okay, this is a 69-year-old person, perfectly in the middle. And to get down to the yellow, it's 14 microns, and that's 36% of what we assume we have to work with. If you happen to start at the 95th percentile, some people do, let's just, if you start at the 95th and it's going to be 56%. If you decide the floor is 40 microns instead of 50, you've still got 29% and 48% before you move from green into yellow. That's something you don't want to miss. That's why you're going to use the software. And then you modify your treatment and your target based on the patient's course. So let's just say your patient's progressed. What do you ask? Well, how fast How bad is their glaucoma? That is, how many steps can I recognize before this person is in big trouble? Was the pressure at target? How long is the patient going to live? If somebody's changing rapidly and they're at target, and you think they were taking their meds, just you always want to re-examine to make sure there's nothing else going on. But particularly if somebody's at target and they're changing rapidly, you want to make sure you're not missing something. And then generally you're going to refer for surgical evaluation. If they're changing rapidly, they're not at target. Again, you're going to want to look at them, but you're going to generally refer for a surgical evaluation. They're usually not at target for a reason. You can't get there, or they won't take their medicines or whatever. They're intolerable. If somebody is gradually changing, you want to determine if you need to make any modification whatsoever. If it takes 15 years to show a small increment of change in somebody with early glaucoma who is 82 years old, you don't necessarily need to do anything. If somebody's younger, if somebody has, relatively advanced glaucoma, then yes, you're going to need to do something. And if so, you need to reset your target, generally about 25% below the average pressure the patient has been running while they have gotten worse. Okay. Not pre-treatment. We're into what they've been doing while they've been getting worse. And then you try to get there. So if the patient hasn't been treated, it's drops or laser. If they're on meds and they've had no laser, you send them for laser. Now, here I would explore compliance, because if somebody isn't taking their drops, you may not need to change your target, okay? If they haven't been using drops. If the patient's had a laser and they're not on meds, obviously you're going to add laser. If they're had a laser and they're on one med, you're going to add a second med. If the laser is done and that they're on target and they're not on meds, then you absolutely need to lower your target, because compliance isn't a question here. And generally you're going to add meds. Depending on the severity, you may refer for a surgical evaluation. If a laser has been done and the patient is using as many drops as is reasonable, you're going to send them for a surgical evaluation. That doesn't mean they're necessarily going to get incisional surgery. That's going to be a judgment call based on the person who's doing the incisional surgery. But I think those people should be referred. Then you have to decide who to refer them to, okay? And if you are somebody who has a number of referral options, that this really is a choice. You're going to want to choose somebody who is familiar with all of the current surgical options in most cases. And these have changed over the years. If patient is phakic, they may be a candidate for combined surgery. So you really want to send them to somebody who is a skilled cataract surgeon. And I think, once again, if you have a range of referral options, you might want to consider the age of the person you're sending them to, because even if the patient's going to come back to you, people in glaucoma, ophthalmology, optometry relationships, ideally you don't change either one very often. So if you have a relatively young patient who needs surgery, you would prefer, I think, in general, to send them to somebody who isn't going to be retiring in the next 4 or 5 years. Because if they need another operation, it would be nice to see a person who saw them before, because we all are, as surgeons, have our own way of going about things. And patients generally kind of like to see the same doctor, and they will tell you if they don't want to. So, that's fine. So I would think about the age of the surgeon in relation to the patient's age. And after your intervention, you need to establish a new baseline. If the reason you did something is that the field's progressed and you repeated it, you've now got your 2 new GPA baselines, so you have to go into the machine and change them. Unless you did surgery or highly unlikely added a myopic, because that would change the visual field. Repeat your optic nerve studies, pictures, and OCT, and then you restart your schedule. Key points: a good baseline is essential. Either fields, OCT, or photos may show progression first. And there are usually multiple rational ways to care for patients, but all of the ways you take care of patients involve keeping track of what you're doing. Okay. Thank you. Any questions? Yeah.
I was just curious, how much weight or consideration do you have regarding family history? That wasn't totally, it was addressed as a risk.
Well, it's a risk. Yeah.
Was it heavy? Like,
You know, you have to find out what the family history is. You know, if Uncle Joe and my dad and grandma and Aunt Mildred all went blind from glaucoma, and I'm seeing somebody who's 34 years old with pressures of 26 and I don't diagnose glaucoma, I'm terrified. Okay. As opposed to if those same people got onto drops when they were 64 and all see fine when they're 83. Family history varies. So do I take it seriously? Yes. But it also depends on what the family history is. Doug.
Yeah, I'd add to that, and you said it, but just to emphasize it, it makes a difference whether the family history is a family history of having received glaucoma treatment,
yeah,
which they may have been an ocular hypertensive, or whether they have actually lost vision because of glaucoma. I mean, that's a distinction to make when you're asking the patient.
And people often won't know about that.
Yes, and that's a problem.
But you will usually know if a bunch of people in the family went blind. Yes, Doug? Yeah.
It's been mentioned, the importance of getting multiple IOPs at various times of the day. Do you have any guidelines for getting one pressure within a certain period of time from awakening for that, to get that span? And what did your—
Oh my goodness, I grew up as a resident in the days of admitting people for round the clock pressures. So,
Oh my.
yes,
Yeah.
well, so did you, Paul.
Yes.
Yes. So,
Because the resident was doing it.
yeah, that's right. I was one of the residents. I do try to get people to come in first thing in the morning. But that's about first, early, middle, late. Early, middle, late, ideally. You don't always get that. But, you know, when you're trying to say, well, I'd like to get this 25% below the pre-treatment pressure, and you only have one pressure, you could be at the top of their curve, you could be at the bottom of their curve. And once again, if somebody comes in with a pressure of 49 and marked cupping, you are not going to bring them back. Well, okay, just for the record. But in general, most patients will benefit more from getting several pressures over the course of a period of getting a baseline together than they will benefit from an extra couple of weeks of latanoprost. Okay, I think those multiple pressures beat the 2 or 3 weeks of latanoprost. Yeah.
Your initial risk assessment incorporate LASIK,
Well, they have a thinner cornea. Okay, so, and thin corneas make you more worried. And that's about it. Okay, when I was already doing this when LASIK came in, and it took a little while for the light bulb to go off that, oh, if patients have LASIK, then gee, maybe their measurements are going to be different and maybe we have to start thinking about this. But I think it is now something that is pretty well known. I don't generally think about it at all, other than that you know, they're myopic. And you generally worry about people who are myopic more. That is their eyes, their glaucoma risk is the risk of myopia, not the risk of whatever refractive error they happen to have now that they've had it surgically altered. But not particularly.
Turning history around, what do you tell patients about informing members of their family to get checked?
Oh my God, the best, community screening may be not particularly useful, but you tell them that you want them to have their children and their brothers and sisters and their family members checked. Thank you for bringing that up, because that's useful screening. Okay. That's a very good way to identify people. Have your children been checked? Well, how old should they be when they're checked? How old are they? Yes, they should be checked. It's pretty much like that. Yes.
Maybe a little bit of a philosophical question, but one thing that I struggle with a little bit is trying to impart the perspective of a long-term disease in a trainee who's going through in a 3-month or 4-month rotation. Do you have pearls or suggestions for us trying to, kind of talk about that?
I don't have on this particular set of slides, and I wish I did now that you asked that question, a glaucoma progression analysis of a patient who had been sent to resident glaucoma clinic for a surgical evaluation. I think because their pressure was a bit above target for 2 visits in a row. And I actually went back and got the paper chart and found all the pictures. And and so we had like this 17-year history, and over 17 years, there had been a very small change. And I gave it to the patient. I said, listen, anybody wants to operate on you, you show them this. But it's not easy.
I'm going to talk about that.
Excellent. I won't have to worry about it. It's a slow moving disease, but it's cumulative.
Yeah.
And we talk about how often to see people. Doug said something a few years back, a lot more than a few years back, about how often to see people. And you may have noticed that I didn't have any recommendations for following somebody up in 2 years, even if that might have made sense. Because what you said, Doug, was that if you tell people to come back in 2 years, they believe that there's nothing wrong. If you tell them to come back in 1 year, they believe they might have something. And I think there's a significant amount of truth in that, which doesn't exactly answer your question, but I just wanted to get that in. Yes, Paul.
I find it very useful at the first visit to talk to people about what do we know about glaucoma? Why does it happen? What's the risk of going blind?
Most people don't go blind. Glaucoma is a blinding disease. Most people don't go blind.
And that we have clinical trials that have shown us that we can measure, we're really lucky, we can measure the tissue, we can measure the function with really important accuracy. And I can show you those results as we go along.
That's the patient.
So that you can be confident that you're doing well. Or if we make a decision to do something that is based on solid evidence and the results of information.
That's the patient. Her question was the trainee. I don't have a magic bullet you tell people, but other than pulling out cases where, and obviously the other thing that you want to show people is the flip side, which is somebody who, like, it's the grass growing, somebody who, if you only looked back at the last field, they never changed.
Right.
Whereas if you go back to the first field, you look and it's, oh my goodness, this is steadily going down. I probably should add those to this, but I didn't because I had 40 minutes.
Just a quick comment. For those who aren't familiar with the book Clinical Decisions in Glaucoma, both the first and the second edition, it really, really is good. And you guys did such a great job with the second edition. So I would definitely download it. I had shamelessly kind of copied some of the algorithms. You kind of talked about some of the things, but
There's
an algorithm that's so good.
Yes, and they're, once again, they're arbitrary. But you're steering between grievous undertreatment and grievous overtreatment. And it's a manual and it's not aimed at a glaucoma expert. Okay. It's aimed at somebody who isn't a glaucoma expert. So yes, I was very proud of the first edition. Peter did most of the work on the second. I'm very proud of that as well. Once again, if y'all want that copy of that to post on your society websites, we'd be happy to do that. I spoke to both Peter and Pradeep before I made this offer.
The only other, I love in the first book, I can't remember if you did it in the second book, but you talked about target pressure, right? And what always resonates with me, your verbiage was that it is arbitrary and imperfect. And
yes,
so,
as is so much that I have said today. Other than that, it's important to get a good baseline and take pictures. Okay.
Well, the thing on target pressure is it's probabilistic based on clinical trials. So if somebody has a 30% chance of getting worse, that informs you, but it doesn't tell you that is one of the 30% or one of the 70%, but you at least, it is based on information. And I'm going to talk about that.
But it's something else. It tells you, it allows you to stop. Okay. It's really helpful to say, okay, given this some thought, I don't have to keep adding medicines. It's okay. We're far enough down. We're now going to follow the patient. You know, most people don't take 3 different bottles. You may give it to them. Okay. But most people don't take 3 different bottles of medicine. They'll take 1 bottle. They'll maybe take a drop in the morning, a drop. And this is not, once again, not 100%, but most people don't take 3 bottles of medicine. Do your patients take 3 bottles of medicine, David? Yes.
Did you mention giving written instructions to patient?
Instructions help, but I will stand by most patients don't take 3 bottles. Picture time. Don't run away. We're supposed to have a picture, right?
But or pick.
Last question, any other comments? I think it was a great session for the morning. Thank you.
Thank you for your attention.
Let's orderly come down and
So
grab.
John, yes, maybe we'll take a picture this way. So we'll have everybody sit here.
Okay. You
And then everybody else walk over to here to fill in the sides and behind, maybe back there, you can just stand up. And, you know, and I think that probably is the best. At least that's what I thought, at least try it.
So my job is
Just you sit here, right here, just sit right here. And then I'll show it.
This is the kind of work assignment I like.
Good to see you, man.
Professor, how are you? I was wondering, how did you choose Supi today?
I
Just take a seat. Just
have metastatic prostate cancer.
Yeah.